Well, welcome everyone. Thank you so much for attending the Moyamoya Foundation Virtual Seminar, an evening of listening and learning from leading experts about Moyamoya research and clinical practice updates. If you require the use of closed captioning on today's presentations, you can enable them on Facebook Live by clicking the ellipses in the upper right corner. Please feel free to use the chat feature if you have any questions. We will take an approximately 50-minute break after the first four speakers, around 6:30 p.m. My name is Catherine Stratton, Vice President and Research Chair of the Moyamoya Foundation, and it is my great pleasure to have you all here today. The Foundation is committed to advancing Moyamoya research through collaboration with clinical and academic experts. We hope that through initiatives such as this seminar, we can provide the Moyamoya community with the most up-to-date information and resources. With that, I would like to pass it on to my wonderful co-hosts, Sophia Kocher and Liza, who will be introducing our speakers this evening. Please enjoy the event.
Hi everyone, my name is Sophia and I'm a member of the Board of Directors of the Moyamoya Foundation, where I lead the Patients Grant Committee and help with our research initiative. I'm passionate about using my experience as a Moyamoya patient to improve outcomes for others. I was diagnosed with Moyamoya disease at age 2 and underwent surgery to bypass the narrowed vessels to my veins and restore blood flow. Inspired by my own treatment, I am working to become a physician and I'm currently a medical student at Duke University. And I'd now like to introduce you to my co-host, Liza.
Hi, everybody. Thank you, Sophia. Thank you, Catherine. My name is Liza. I'm a Moyamoya patient advocate and a board member for the Moyamoya Foundation. I had my first stroke at age 21 and was finally diagnosed correctly with Moyamoya disease 18 years later after my fourth stroke. I also underwent bilateral revascularization surgeries. I have been a lead volunteer advocate and national spokesperson for the American Heart Association for the past 2 decades. I've spoken nationally about my experience with stroke and now Moyamoya disease. I have co-founded the Sisters at Heart Foundation and also authored The Faces of Moyamoya Disease. I'm thrilled to be here tonight. And as we get started, I would like to thank each of you for joining us. We have a goal at the Foundation to help reach our mission of increasing awareness of Moyamoya disease, promoting and supporting research of the disease, and providing assistance to Moyamoya patients. We are doing that tonight. If you're interested in donating to our foundation so we can continue to provide educational seminars such as this, we invite you to our website to make a donation. Thank you in advance. But we are thrilled to get started with our first speaker. Mr. Dulanka Silva is a consultant pediatric neurosurgeon at Great Ormond State Hospital for Children. In addition to general pediatric neurosurgery and hydrocephalus, his specialist expertise is in pediatric cerebro-neurovascular surgery. He completed his medical training at the University of Cambridge, including a master's in philosophy, investigating the role of oculomotor movements in Parkinson's disease. During residency, he completed specialist training in pediatric neurosurgery, followed with completion of the Pediatric Neurosurgery Fellowship at Great Ormond Street Hospital for Children in 2019 and 2020, after which he was appointed as consultant pediatric neurosurgeon at Great Ormond Street. Today, Mr. Silva will be presenting an overview of surgical revascularization for pediatric Moyamoya, and we are thrilled that he is here from London to speak with us today. I pass this on to Mr. Silva. Thank you.
Thank you very much from the entire team of the foundation. It was inspiring to listen to everyone's stories, actually. So it's a great pleasure for me to be here. And thank you so much for giving me the opportunity. I just want to make sure that people can see my screen, first of all. Can people see my screen?
Yep.
Wonderful.
Yes.
Wonderful. So I'm going to talk a bit about surgical revascularization in the treatment of pediatric Moyamoya. And I think there are 4 objectives that I really want to cover. The first is I want to take a bit of time to talk about your child's journey from diagnosis to operation. I want to talk a bit about the operative techniques we utilize in pediatric patients with Moyamoya. I also want to emphasize a bit about how we achieve excellence in standards of care for pediatric Moyamoya. And of course, maybe finish off with some aspects on how we apply these principles that we've learned to the treatment of other pediatric vascular pathologies. In terms of indications for the revascularization itself, this remains the primary treatment modality for children with Moyamoya disease and Moyamoya syndrome. And this is something that's supported by the Japanese Ministry of Health and Welfare guidelines, as well as the American Heart Association. And if you have a symptomatic Moyamoya, then you should undergo surgical revascularization. If you have radiological evidence of Moyamoya, symptomatic disease, strokes, or transient ischemic attacks, and you have clinical or radiological compromised blood flow, then surgical revascularization is absolutely indicated. We know from the earliest papers from Japan that untreated in symptomatic patients, nearly 65% continue to progress, with up to 40% chance of neurological morbidity and impairment, and a 3% mortality rate. And the American Heart Association guidelines in the management of patients and children with Moyamoya, therefore, are united in really saying that surgical revascularization is absolutely indicated. The aims of revascularization is really to use an alternative source of blood to augment the cerebral blood flow and the perfusion to the brain, and to reduce the future risk of stroke. It is important to understand that it doesn't reverse the underlying arteriopathy. It is just to provide a new source of blood. And because the external carotid artery is classically spared in Moyamoya, this is an excellent source of providing blood to the brain to bypass the internal carotid artery narrowing. There are multiple sources of the external carotid artery that can be utilized, including the lining of the brain, or the dura, muscle in the scalp, temporalis muscle, the galea, which is another layer in the scalp, using multiple burr holes in the skull, whereby you make holes in the skull and you pass some of that tissue into the brain. You may have heard of the superficial temporal artery to middle cerebral artery bypass. This is called a direct bypass surgery. And of course, the Pulcine angiosis technique popularized by colleagues at Boston Children's Hospital and Professor Michael Scott. We can use other sources of blood flow to the brain from elsewhere in the body. Historically, people have used fat or omentum from the tummy and passed on to the brain. This is much, much more rarely required now with all the other techniques and advances in the surgical techniques. In terms of operative techniques, really there are two strategies in treating Moyamoya in children. One is the classical direct revascularization technique, whereby you utilize the superficial temporal artery from the scalp and you make it and you suture it to a branch on the surface of the brain, so-called a direct bypass. This has the theoretical advantage of immediately providing some new blood to the blood vessels of the brain. However, in children in particular, there are a number of issues with this technique. Firstly, blood vessels in children are incredibly small, and therefore, from a technical standpoint, are incredibly difficult to suture without the graft itself thrombosing. The other important consideration is that when you do the bypass suturing, you have to clamp the recipient vessel for a short period of time, and therefore, in a child with a potentially ischemic brain, this can potentially add to risk of stroke during the surgery. The other techniques, the other collection of techniques are the indirect revascularization techniques, whereby you essentially utilize all of the above mentioned sources that we talked about from the external carotid artery, and you bring this tissue into apposition over the brain surface, and new blood vessels grow in over time. You can see here an example of the muscle synangiosis, where the temporalis muscle is sutured. Here you can see evidence of the dural arteries themselves being utilized to provide new source of blood. Here you can see an example of the Pulcine angiosis utilizing the superficial temporal artery in the scalp. And here you can see a combination of those techniques where you utilize both muscle and the arteries. And here finally, you see the multiple burr hole technique, which was developed in France and commonly used in Necker Hospital, whereby multiple holes in the skull are used to bring that tissue from the scalp in apposition to the brain. There is excellent evidence that there is no difference in direct versus indirect techniques in the treatment of children with Moyamoya. Both are acceptable. We note that following surgery, nearly 90% of children will achieve a symptomatic improvement. A small proportion remain static and don't progress, but of course, a very, very small proportion do continue to deteriorate. But this is in stark contrast to untreated Moyamoya, where over 65 to 70% will progress. There is, of course, a perioperative risk that comes with Moyamoya surgery, and that's a stroke rate of about 4.5 to 7% in the best of hands. This data is also supported by a more recent meta-analysis that my colleagues and I published about the different techniques for Moyamoya surgery. And we demonstrated the benefit of indirect techniques, both in terms of the surgical morbidity it can create, in terms of a better profile in terms of surgical morbidity, but also a wider area of revascularization. And the American Heart Association guidelines also do mention that whilst both approaches are technically possible, the indirect approach appeared to yield a greater quality adjusted life years over 10 years after surgery. However, in practice, the preferred approach does vary between institutions. Just to summarize at Great Ormond Street, our primary technique for the standard cases remains the indirect revascularization. We utilize the middle meningeal artery of the dura. We perform a Pulcine angiosis with the superficial temporal artery and suture it to the brain. We also suture the cuffs to the dura, and we use the muscle as well. I'd like to just take a moment to talk a bit about achieving excellence in standards of care in pediatric Moyamoya. For me, through my experience and my colleagues, I genuinely believe that it is not just the surgical technique that helps achieve the excellent outcomes. I think far more important than surgical technique is understanding the biology of Moyamoya and understanding the disease. And patient selection is the first step in achieving excellence. You have to see Moyamoya as a condition where biology is really at work. In children, the concept of a hungry brain is essential to understand. If you have a child and their brain is hungry, then they will have the ability and the capacity to bring in new blood flow if you can provide it. This leads on as surgeons for us to understand that our role really is to facilitate in the safest way what the body wants to do by itself when they have a hungry brain. And our role is to try and perform a surgery that is the safest, the fastest, with the least amount of risk for the patient. And if we understand this, then we can understand and appreciate the best techniques to use for treating this condition. The third critical factor is really understanding that the perioperative management of your child is absolutely crucial in great outcomes. And it is far more important to optimize this than purely basing the success on surgical technique. And this is where optimization of your patient with multi-specialist coordination between pediatric neurologists, pediatric neurosurgeons, specialist neurovascular nurses, and radiology colleagues who are dedicated to looking after these children is absolutely crucial. It is the anesthetic and the perioperative course that is often the greatest source of morbidity to these fragile patients. You have to understand and think about the role of aspirin before surgery. You have to ensure that these children are admitted the day before surgery to hydrate them with IV fluids so that they don't have significant blood pressure shifts. You want to avoid low blood pressure, pain, hypocarbia, which means hyperventilation and carbon dioxide in the bloodstream being too low. You want to ensure their temperature is appropriately controlled. In specialist conditions like sickle cell disease, you want to optimize them before surgery to make sure their blood levels are appropriate. You need to think about adjuncts such as intraoperative EEG monitoring to ensure the safety of your surgery, avoid diuretics, and achieve a balance during your anesthesia of ensuring that the supply and the demand for the brain is really optimized. And it really is when you understand and put together all of these concepts that you really, really realize that the management of the child with Moyamoya and your outcomes are far more reliant on right patient selection, right perioperative management, than just focusing on the surgical technique. And this is why you have improved outcomes when these patients are managed in high volume centers. And this is another way in which you can consider achieving excellence in looking after these patients. This is corroborated again with the American Heart Association guidelines, which talks about how data from a national database demonstrate how if you have a center that manages more than 30 pediatric cerebrovascular cases a year, they would have shorter lengths of stay in hospital, a much more likely faster discharge home, and a 15-fold lower rate of death. And this, again, adds to the importance of subspecialization and managing children in centers of expertise, where a high proportion of patients with this condition are observed. If I continue, the importance of collaboration with centers of excellence. It allows you to develop multidisciplinary working with your colleagues. It allows you to discuss with experienced colleagues complex cases and make decisions which are more nuanced in this complicated cohort of patients. And of course, you can learn from the experience of other experienced surgeons. A really important surgical adage is that a good surgeon learns from his own mistakes, but an even better surgeon will learn from the mistakes of others, because you can't buy that experience. And of course, the opportunity to further the field by developing research and networking links. I'm incredibly privileged and proud that with my colleagues in Boston Children's Hospital and Toronto Sick Kids, my colleagues at Great Ormond Street, we have established a Boston, London, Toronto collaborative, whereby we regularly meet on a monthly basis to, of course, work and discuss complex cases, talk about research avenues, talk about further advancing the field, but also it's another opportunity for a great bunch of colleagues to become friends and, of course, be united in taking great pleasure in trying to, care for these children and find ways to further improve our understanding of the disease and the condition itself. If I take an example from my own experience, 4 or 5 years ago, my colleague, Dr. James, who's going to be speaking next, and we had to take over the Moyamoya service from our senior surgeon who established the Moyamoya service. And this is very, very difficult. How do we achieve excellence? How do we maintain standards of quality? And this is a paper that I published, having reflected on the first 2 or 3 years of our own experience in developing our Moyamoya service and taking over from our colleague. It was important to have a cycle of learning, whereby we would ensure that we had didactic learning to learn the skills, to manage these patients, to identify the patients. We would learn the operative techniques with the progressive escalation in independence. We ensured there was a peer review process where we evaluated operative videos, operative metrics, evaluated outcomes, and identified areas for improvement. And through that progress, what was of great delight to our senior colleague from whom we took over the service was that we demonstrated not only achieving and sustaining the excellence, but also we were able to improve some of the outcome metrics in the management of these children, demonstrating that this can be taught to new surgeons, to a new generation of surgeons, and we can achieve those standards of excellence throughout. But it all comes down to that aspect of the factors that help achieve that excellence: working in high volume centers, collaboration with experienced colleagues. And as you can see, in terms of our outcomes from that early cohort of patients that we independently looked after, they were just as good as the very best series in the world. And of course, how do we progress things further? How can we translate these principles into difficult cases and even potentially other vascular pathologies? For example, we know that other territories of the brain can continue to be affected with Moyamoya. Our standard PO synangiosis technique often revascularizes the middle cerebral artery territory, but we know that in a small proportion of patients, they can develop disease in the anterior cerebral artery territory, in the posterior cerebral artery territory. How can we use the principles that we've learned in performing revascularization in these areas if they're required? The concept of the hungry brain is very crucial. If you bring in tissue sources from external carotid artery sources and get them opposed to the brain, and you remove any barriers, you can achieve a revascularization response. Here's an example of one of our patients who had both anterior cerebral artery and middle cerebral artery disease. And you can see that we conducted a standard middle cerebral artery territory synangiosis, and we used a pedicled pericranial apposition to obtain a synangiosis into the anterior cerebral artery territory. And these have also been described by our Japanese colleagues, and more recently, of course, by our Boston colleagues as well. What about if you have to augment flow if there is disease progression despite adequate successful bypass and treatment? Here is an example of a 6-year-old girl who underwent bilateral revascularization surgery. On the left, you can see the severity of the disease she has. On the far right, you can see an excellent functioning bypass from Pulcine angiosis. But on the right, despite a patent superficial temporal artery, this patient did not have a revascularization response. And the reason was that she had a subdural collection between this artery and the brain that prevented the apposition of this artery. We drained and removed that subdural collection and performed multiple burr holes to additionally augment that region. And 6 months later, you can see that bypass is now functioning, and through the burr holes that we've created, there is new blood coming in. And finally, can we apply these principles and in pathologies which may be different to Moyamoya, but much more harder to treat? Here is an example of a 10-year-old girl who had an untreatable deep arteriovenous malformation. She developed progressive hemiparesis, progressive problems with her speech, and she was struggling to function in school. Her symptomatology was very, very, very typical of the symptomatology one saw with children with Moyamoya. And we, again, through having to be in a situation where you had a child deteriorating in front of you with no option for treatment, we thought about whether we could consider augmenting the flow into the hemispheric regions. Here you can see her deep arteriovenous malformation, and you can see a sign on the surface of the brain known as the Ivy sign, which is an indicator of a hungry brain. Here is the angiogram demonstrating this deep arteriovenous malformation. Notice that the majority of the supply of this AVM is deep with no superficial arterial supply. After much discussion and debate, we considered trying to augment the flow by performing a Pulcine angiosis. And this is the angiogram a year later, which demonstrates good augmentation of flow into the hemispheric regions in an AP angiogram, and on the lateral runs, good augmentation of flow through the superficial temporal artery bypass with no filling of the AVM itself. She's now 1.5 years post-bypass. Her hemiparesis has stabilized, her speech is completely normal, and she has more energy. Again, this is not common. It's very rare, very unusual, and these are difficult cases. But we can use the principles that we have learned from managing Moyamoya and potentially apply it to these rare, difficult to treat patients. Final thoughts. Children with Moyamoya disease are complex, and they require multidisciplinary input through all stages of their journey, from diagnosis to surgery to the postoperative care and follow-up. Indirect revascularization has a significant number of advantages in children for revascularization compared to direct techniques. Our primary technique and procedure of choice is the indirect revascularization. There may be very, very rare situations where a direct procedure may be needed, but this is incredibly rare given the advantages that we have with the indirect technique. The final choice, of course, depends on the institutional experience and the surgeon's experience. And finally, children with Moyamoya disease should be, as a standard of care, managed in high-volume centers with multidisciplinary input and experience from all the relevant specialists to achieve the optimal outcomes and excellence in care. I'd like to thank all of my colleagues at Great Ormond Street that I work with on a day-to-day basis, who are absolutely exceptional and work every day to help us achieve great outcomes, as well as, of course, my colleagues from Boston and Toronto, who I've had the pleasure of working with very closely over the past 5 years to foster excellent research relationships, but also to learn from. And pediatric neurosurgery is a team sport, and teamwork always makes the dream work. And finally, I just want to say thank you to all of our patients for the privilege of trusting us and allowing us to try and do the best we can for you. Thank you very much.
Wow, what a start we've had. Thank you so much, Mr. Silva. I believe that was just an amazing presentation, and I loved hearing about not only the neurological piece, but collaboration, teamwork, and really it's what we're trying to do here tonight. So thank you again for your presentation. We really appreciate it.
Thank you very much.
I now would like to take a moment to introduce our next speaker, Dr. Liza Pulcine. Dr. Pulcine is a pediatric neurologist at the Hospital for Sick Children who specializes in caring for neonates, children, and adolescents with stroke. Her clinical care and research focuses on all aspects of childhood stroke, including etiology, diagnosis, early treatment, prevention, and rehabilitation. Following medical school at the University of Ottawa, Dr. Pulcine completed the pediatric neurology residency program at Sick Kids. She belongs to the International Pediatric Stroke Organization, the American Congress of Rehabilitation Medicine, and the International Child Neurology Association. Today, Dr. Pulcine will present on transition from pediatric to adult care. Thank you, Dr. Pulcine.
Hi, good afternoon, or I should say good evening from Toronto. Just first and foremost, I want to make sure that everyone can hear me and can see my slides.
Yes, we can.
Perfect. Excellent. Okay. And then I would like to thank so much the Moyamoya Foundation for inviting me to give this presentation. I'm very honored to be able to do so. I am by no means an expert in Moyamoya disease. I love all pediatric stroke, and that's why I'm in this specialty. And my colleague and mentor, Dr. Noma Delamini, who couldn't be here today, is by far way more experienced than me, but she's taught me a lot about Moyamoya. And so here I am, and I'm going to be talking about building a bridge from pediatric to adult care. A hot topic right now in pediatric care is transitioning our patients into adult care. So I have no, sorry. There we go. I have no actual or potential conflicts of interest in relation to this talk. And I'm going to cover the next 4 learning objectives in the next 15 minutes. So I want to first start by describing the timing and challenges associated in transitioning adolescents with neurovascular disease, specifically with Moyamoya, to adult care. I want to delineate the key components of transition preparation and implementation, describe our current process of transition and ways to improve it, and describe the measurable outcomes of transitional care. And if we have some time, I will go over a nice natural history study that one of my colleagues had done to talk about how our patients are doing in the adult world. So first, let's lay a little bit of context. I wanted to emphasize that little kids are not adults, and that pediatric stroke has different etiologies that are often multifactorial and are often very different from the adult stroke etiologies, as most of you here know. And so the International Pediatric Stroke Study came up with the standardized classification system back in 2012 called the Cascade system. It really talks about the etiologies that are common to pediatric stroke, 30% of them being cardioembolic, but actually 50% of them being arteriopathies, which are both genetic and acquired. And where Moyamoya patients lie are in these bilateral cerebral arteriopathies, which again can be genetic or acquired. The other big difference between pediatric stroke and adult stroke is that clinical presentation really depends on the age of the child. We know that when neonates have seizures, they're usually on our differentials a risk of having a potential stroke, and infants can have fluctuating neurological symptoms as a result of different collaterals to the brain. And so they don't often present with a focal neurological deficit for someone to think of stroke, and their exam often fluctuates. And to be fair, they're very difficult, can be challenging to examine. A lot of our chronic critically ill children, for example, that have congenital heart disease, often are sedated and have pharmacological paralysis, and as a result are difficult to examine. So for all those reasons, there's often delays to diagnosis. And when I think of pediatric stroke, I think of finding where's Waldo, and Waldo is right here. But apart from neonatal arterial ischemic stroke, really pediatric stroke has many different presentations, many nuances in the risk factors. And so no two strokes, even within the same etiology like Moyamoya, are alike. And as I mentioned before, we often see both pre-hospital and in-hospital delays to diagnosis. This is a study from one of our previous stroke fellows, who's now a pediatric stroke neurologist in Winnipeg, Mubin Rafe, who looked at all children presenting with stroke to the hospital for sick children. This was back in 2009. And the median time from the onset of clinical symptoms of stroke to the time of actual neuroimaging diagnosis of stroke was almost 24 hours. So as you can imagine, this can often delay some of the more hyperacute therapies that are available for pediatric stroke. And while pediatric stroke can lead to, may not lead to morbidity, can lead to lifelong disability. So we know there's lower mortality, but higher morbidity. And the impact of childhood stroke lasts well into adulthood. We often talk about children growing into their deficits. Almost 3/4 have motor or language or cognitive impairments. And another 2/3 of children have lasting motor deficits. A third may develop epilepsy, and problems with cognition, language, and executive function are also often found. So when it comes to the patient's journey of care from childhood to adolescence with chronic disease such as Moyamoya, they often encounter several challenges, and those include difficulty engaging with the adult services, medication adherence, especially in the adolescent years, missed medical appointments, and really this highlights the higher healthcare cost that can result as a result of all three of the previous variables mentioned above. For the healthcare provider, often when physicians are surveyed, especially in the pediatric neurology world, about 2/3 are not comfortable in providing adequate transition to their adolescent patients with chronic disease such as Moyamoya. And the reasons that have been highlighted from one of the working groups at the University of Toronto between the pediatric and adult transition is not knowing whom or when to refer for adult care. Now, our epilepsy colleagues are much better in having standardized pathways, and our neurovascular team is working now to implement similar ideas in order to improve this. We're also reviewing an overwhelming volume of clinical documentation during transfer of care. So some children that present with Moyamoya, when they're just a few years of age, will have lots of neuroimaging, functional neuroimaging studies, surgical procedures, investigations. And so you can imagine trying to put all that together can often feel overwhelming, both for the patient and the provider. And then finally, not knowing how to empower young adults to self-manage their disease. Often, really, this starts early, so not in the last year of their adolescence and transition to early adulthood, but really from the time of early puberty. We know that pediatric stroke has a high cost of care and rehabilitation burden. And so the Canadian or the US dollar averages here for 1 year is almost 50,000 USDs for median cost of care due to stroke, and almost 100,000 is the adjusted 5-year cost for childhood stroke. So it does significantly affect our healthcare system. And so when we talk about transfer versus transition of Moyamoya patients, we really should think about what is transfer. Transfer is really handing over the responsibility of medical care from one clinician to the next. Versus transition is the process of preparing the youth and their families for both independence, optimal disease understanding, and self-management skills of their chronic disease. And I really like this definition, which is transition, an ideal transition is the purposeful and planned process that addresses the medical, psychosocial, and educational vocational needs of adolescents and young adults with chronic conditions as they move from both child-centered to adult-oriented healthcare systems. So the Canadian Pediatric Society has come up with a statement that talks about the most effective or ideal transition when it comes to any chronic disorder. It starts with early transition planning. So regularly assessing transition readiness with both patients and caregivers, ensuring that adequate time is dedicated to coordinating successful transition and understanding each youth's potential goals for activity, education, recreation, and vocation. And secondly, create an individualized transition plan. So we want to identify transition champion, involve key multidisciplinary clinicians whenever possible, as well as the primary care physicians, and solicit input on care needs from youth and parents, addressing gaps in both youth preparedness, autonomy, and confidence. Then provide support before transition. So key here is to provide education to peer support for youth and caregivers, support youth with a stepwise approach to increasing independence in care and management, and create a comprehensive health transfer summary so that it's not so overwhelming. Finally, ensure ongoing support after the transition to adult care. So often our nurse practitioners will touch base with patients routinely, even when the patient is considered, transitioned, to ensure youth attendant appointments, assess each youth's attachment to adult services, and continue to involve caregiver as per youth wishes. So this is just an example of the number of patients. The number of patients that have been transitioned from our pediatric stroke program, these are all comers, so Moyamoya and others, over the years, as you can see, as we've gone from 2010 to 2020, over a decade, we're transitioning more and more. And we have, one of the advantages is that we do have a dedicated adult stroke neurologist with a keen interest in the care of young adolescents who have both Moyamoya and other etiologies for pediatric stroke. And this really just highlights the etiologies that we have transitioned. So the 31% in orange here is really the arteriopathies without stroke. And so this could be some of our Moyamoya patients. And then the other is usually some of their congenital and acquired arteriopathies with stroke. So you can see that this is a large part of the pie. Aside from Moyamoya disease, we also want to transition our complex arteriopathies. So children that have Moyamoya plus or complex arteriopathies of other genetic underlying conditions, as well as our cardioembolic population and children with posterior circulation stroke. Now, the reason that I highlighted those as well is because all four populations have a higher risk of stroke recurrence and need to be followed into the adult and beyond. So what is our current process here at the Hospital for Sick Children? Well, we do not presently have a standardized approach to transition, and a working group was developed in 2021 between the University Health Network and Sick Kids Hospital in order to address these gaps, which involves all subspecialties of neurology, but including us in neurovascular disease. This may result in important gaps, as I mentioned, in care, especially for a population of patients at risk of recurrent stroke. And so we want to be very good in information sharing in terms of the clinical documentation. So we've been updated to an electronic medical record that now is both used at Sick Kids and at Toronto Western Hospital. And so we can transfer the clinical documentation as well as our laboratory studies more easily. And the neuroimaging is now pushed via our PACS system at the Hospital for Sick Children to the system at Toronto Western Hospital without having to go down to health records and, burn the old school CD. So now this is done in a more seamless fashion. What are some potential barriers in pediatric stroke transition? In terms of the relationships, we really want to create a joint clinic that's attended by pediatric and adult providers so that those relationships can be established early. In terms of setting realistic expectations and beliefs and expectations, so connect patients with peers who have already been transferred and create a structured transition plan. In terms of skills and efficacy, we want to regularly assess and discuss transition readiness. And this has previously been done by our previous nurse practitioner, Ishvinder Batal, and by Dr. Noma Delamini. We also want to have distinct resources in pediatric and adult hospital settings and recognize that those distinct resources may differ between the pediatric and adult settings. So for example, access to MRI services and functional MRI services may be different in terms of the ease with which you can receive these services. Outside calls from families are allowed at our hospital, but may not be necessarily taken at the adult centers. And physician training and experience. So training neurologists with an interest in transition care and stroke. And over the years, we've developed more and more adult colleagues who have a keen interest in pediatric stroke and the adult youth transition program. And so we may be expanding into other hospitals across the Greater Toronto area. I mentioned before our previous NP, Ishvinder Patel, and our a program director of the Children's Stroke Program, Dr. Norma Delamini, have been administering this questionnaire called Am I on Track? This was actually developed by the BC Children's Hospital in British Columbia for all levels of transition with any youth with chronic disease to see how we're doing from the time of early puberty, adolescence, all the way to young adulthood. And so this, if you're coming to our clinic, you may be now being approached to ask if you'd be willing to participate in this baseline questionnaire. And I mentioned about the Am I on Track app. And so there's actually, this has been kind of the Am I on Track transition guide that's been developed by BC Children's Hospital. There's also one that's been developed by the Children's Hospital of Eastern Ontario in Ottawa. And actually Sick Kids is now doing a research project on transition for not only Moyamoya, but for any children with chronic medical conditions. So if you are feeling anxious, you're feeling frustrated, and you want to participate, please reach out to us in the neurovascular clinic, and we'll connect you with the teams that are actually doing this on both a research and clinical basis. So what are some areas of future research? So how do we measure objectively outcomes of transitional care in neurovascular disease, and specifically Moyamoya? There's really been a paucity of literature on transition in pediatric stroke. So how do we assess some possible metrics of success? We want to look at things like rate of appointment completion and follow-up in the adult setting. And so we're going to try and do that with Dr. Cheryl Jacobin, who's our adult stroke neurologist who follows a lot of the patients that have graduated from Sick Kids. We want to look at patient and family satisfaction questionnaires with transition and new providers, look at stable or improved neurological conditions, so the stability, adherence to plans and care, decreased emergency room utilization, which is a big problem given the state of our healthcare system right now, and lack of primary care, and rate of bounce back to pediatric providers, as well as improved quality of life metrics. So in the next few minutes that I have remaining, I just want to highlight a research project that one of our colleagues had done as part of actually a residency research study looking at the clinical and functional outcomes of adult patients diagnosed with Moyamoya disease in childhood who were transferred from Sick Kids Hospital to the Toronto Western Hospital. This data is now old, but it's still interesting to look at, and we're hoping to update this in future revisions. And all of this work was done by Dr. David Pham, who's now a community neurologist at St. Joseph's Hospital in Toronto. So his work looked to determine the rate of recurrent transient ischemic attack, ischemic stroke, and intracerebral hemorrhage in patients presenting with pediatric Moyamoya disease, and determine the long-term functional outcomes using the pediatric modified Rankin scale, or I should say the adult modified Rankin scale for this project. This was a retrospective study review of natural history of Moyamoya disease and syndrome in a pediatric cohort here at Sick Kids. The original cohort consisted of 52 patients, and it's the largest North American, or at the time of this presentation, was the largest North American pediatric Moyamoya natural history study. Patients that were enrolled in the study were 18 years of age and older, diagnosed with Moyamoya disease or Moyamoya syndrome, so either genetic or idiopathic. And they had any initial presentation of their Moyamoya asymptomatic, ischemic stroke, transient ischemic attack, or hemorrhage with baseline confirmatory vascular imaging. So they have to have an MRI or CTA or a cerebral angiogram to show that there was Moyamoya vasculature. And then they were seen or referred to an adult stroke specialist at the University Health Network, namely here, Dr. Cheryl Jacobin. And we looked at baseline characteristics, including age, gender, ethnicity, past medical history, comorbid conditions like neurofibromatosis, sickle cell disease, trisomy 21, post-radiation and post-infection, as well as family history, prior surgical history, and presenting symptoms. And the outcome was looked at the modified Rankin scale with a 0 to 6 scale, 0 meaning you have completely normal functional outcome, and 0 to 2 meaning that you're independent in your activities of daily living, 6 being death, and 5 being bedridden. So just to give you kind of an overview of the scale that was used. So the cohort consisted, somehow my arrows have disappeared. Cohort consisted of 52 patients. 15 of those patients did not have any further adult visits, and 3 patients had insufficient data. So at the end, we were only able to look at 34 patients for the analysis. And so these are the baseline characteristics. The total sample size was small of 34 patients, and we had a slightly higher female to male ratio, lower than the previous studies. And there was only one familial case of Moyamoya at the time of the study. Age of presentation of the cohort was really kind of in the years we know that Moyamoya peaks around 4 to 8, based on the diagnosis was based on neuroimaging. And in terms of ethnicity, we actually had as we know in Canada, we have multiple ethnicities, but the majority of our patients, 3/4 were Caucasian. And in terms of primary versus secondary Moyamoya, so the majority were primary Moyamoya in that 34 cohort group. And then there were a combination of patients with sickle cell, Down syndrome, radiation, and neurofibromatosis. Presenting symptoms in the majority with primary Moyamoya and Moyamoya syndrome were ischemic stroke. And most, the hemorrhage rate was actually very low, contrary to what we think happens in the adult world. And then I'll just skip over for the sake of time to say that the surgical patients, there were 26 patients that had surgery in that 34 cohort. 11 had direct procedures and 22 had indirect procedures. And 11 procedures were unilateral. So we had a combination of obviously patients that had bilateral. And 7 patients of the 34 had to have repeat surgery. 3 had direct and 5 had indirect procedures. The mean time to surgery was about 3.5 years, and the average age of surgery was about 12 years. Indications for surgery were obviously presenting neurological symptoms like progressive white matter changes, vascular reactivity changes on the functional MRI, cognitive or behavioral changes. And there was, very lucky to work with Dr. Peter Dirks, who'll be speaking to you as well at the seminar. We only had 1 postoperative stroke reported in that group, and 3 patients with crossover into the surgical group from non-surgical group, followed by vascular recurrence. And again, this just points out the surgery group based on Moyamoya disease, sickle cell disease, trisomy 21 radiation, and NF1. In terms of the recurrent vascular events, the annual risk, most recurrent events were transient ischemic attack, not actual confirmed stroke. And the hemorrhages occurred both in the same patient and did not capture cognitive changes, silent events, seizures, or migraine related to Moyamoya. So none of the vascular complications that are not stroke related. The time to recurrence really was kind of evenly spread. And so the recurrence by subtype, there was no significant difference in recurrence between Moyamoya syndrome and the subtype of Moyamoya syndrome. And 1 patient with sickle cell disease had 3 recurrent events, 1 ischemic and 2 hemorrhagic. In terms of the outcome and the long-term follow-up, the initial modified Rankin scale, the majority of patients, as you can see, had a score of 0, 1, and 2. This is good functional outcome and independence. And there was no death, but we did have a few patients that unfortunately had an MRS of 4 and 5. And this is the MRS at the last follow-up. And in this cohort, there were a few patients that had passed away. But again, the majority were in the cohort with good functional independent outcome. And there was no significant difference in the mean initial MRS, last follow-up MRS, or change in MRS between the surgical group and the non-surgical group. So in conclusion, there was a lower female to male ratio other than the other reported North American studies. Again, this is a very highly selected biased cohort, but just an interesting interpretation. The recurrent vascular event rate was very low, lower than most North American studies reported before. The occurrence rate between non-surgical and surgical patients is almost identical, and there was no significant increase in recurrence rates between Moyamoya disease versus Moyamoya syndrome patients. And there was no significant difference in terms of functional outcome between surgical and non-surgical groups. Maybe this speaks to the fact that we are selecting the right patients for surgery that actually needed. And patients gradually did well in terms of their outcome and the outcome length that we had. And we'd like to update this data with our more recent cohort of graduates. Obviously, there's lots of limitations to this study, including small sample size, estimating MRS scores, and just the nature of doing a small retrospective study. And in the future, we'd like to also look at non-vascular recurrent events, including other outcome measures that are often overlooked and they're not captured by the modified Rankin scale, like neuropsychological testing, cortical atrophy, and white matter lesion burden. So I will stop there and thank you again for inviting me to give this presentation. And thank you so much for everyone that works with us at the Hospital for Sick Children, all our collaborators, and most importantly, the patients and the families that make this work possible, and really contribute to our understanding and knowledge of this disease process. Thank you.
Thank you so much, Dr. Pulcine. What an important topic to highlight and discuss, and we are honored that you were here with us today, and so we appreciate your time and your expertise. Thank you very much. It is now my pleasure to introduce our next speaker. Mr. Greg James is a pediatric neurosurgeon at the Great Ormond Street Hospital. His clinical and research interests include craniofacial surgery, cerebrovascular surgery, complex CSF disorders, and head injuries. In addition, Mr. James strongly believes surgical and academic excellence goes hand in hand and regularly presents and publishes research internationally, as well as holding multiple local and national neosurgical training roles. He is an honorary senior lecturer at University College London, as well as an honorary consultant neurosurgeon at the National Hospital for Neurosurgery and Neurology. Dr. James is not able to be with us today, but he has sent a video for us to play. Let's get ready to hear his presentation entitled Making Moyamoya Surgery Safe.
The title of my talk, Making Moyamoya Surgery Safe, is something I have a passion for, and I'll try to communicate why in my talk. It's pretty obvious why safety is important, but I think in Moyamoya surgery, it's particularly important for families and children to feel safe. And that's because it's an operation, when we're thinking about an operation for Moyamoya, usually a ECIC bypass or PHIL angiosis, we're thinking about doing an operation to stop problems happening in the future. So quite often in neurosurgery or other fields of medicine, you bring us a child who's very sick, for example, after a banging the head or bleeding into the brain, and we do an operation to save their life or make them better. And making a decision there is very easy for a family. If your child is sick and an operation can make them better, of course you're going to have the operation. In Moyamoya, it's a little bit different. Quite often children are very well when they come to us. The diagnosis may have been made after a neurological event from which a child is fully recovered, a small stroke or a transient ischemic attack, or increasingly, the child may not have any symptoms at all. The diagnosis may have been made on scans performed for some other reason. So you're asking, or we as neurosurgeons are asking you to trust us, put your child's life in our hands with a child who at that time is well, to prevent a problem happening in the future. And Moyamoya surgery is designed to prevent strokes from happening, months, years down the line. So it's really important that surgery is safe so that you can feel confident in making that decision of putting your child through an operation, which, may not benefit them immediately, but rather is something to help in the long term. And that's why it's really important to understand this balance between, on one side, the natural history of a condition. So when doctors talk about natural history of a disease, it means what happens if we do nothing? If we don't treat this patient with this condition, whatever it is, in this case, Moyamoya, what happens if we don't operate? And one of the problems we have, because Moyamoya is a rare condition, and because it's not really ethical to do a randomized control trial, no family would agree to that, quite rightly, we don't have a huge amount of very good quality natural history data. Japan, which is the country where Moyamoya was discovered and named and has a very high prevalence of the disease, has done some work looking at groups of populations to look at what happens over time. But generally, our grip of natural history is limited. We do know much more about symptomatic patients. So patients who, for example, had a stroke and have Moyamoya, we know are very likely to have another stroke if we do not operate. But for some patients, for example, those who present without any symptoms, but the Moyamoya is detected on an MRI scan, which may have been done for another reason, we don't really have as much knowledge about what would happen in unoperated patients. It's always important to bear that in mind when making a surgical decision. So on one side, you've got the natural history, what happens if we don't operate, and we know that certainly some children with Moyamoya will go on to have strokes, particularly those who've had strokes before, those where the blood supply to the brain looks very, very tenuous. But on the other hand, we have to think about our surgery, and obviously, is our surgery successful? And one thing we are pretty confident is that Moyamoya surgery does reduce the risk of stroke. There's a lot of data that suggests that it's a very effective operation at stopping stroke, but it does have risks. And when we talk about risks of brain surgery, you're talking about important risks, small risks of things like bleeding or infection, but more importantly, because the blood supply of the brain in Moyamoya is already very compromised, the very act of giving a general anesthetic or operating on the brain can destabilize that further. And even in centers like ours or Boston or Toronto, where there's a huge amount of experience in Moyamoya surgery, complications still happen in the form of strokes. And really what we are trying to do is drive down that risk as low as possible. I don't think we can ever eradicate it completely in Moyamoya, but drive it down as low as possible, which means that balance is much more in favor of surgery than in the natural history of a condition. So how do we achieve that? We have to look at all the factors in the pathway. So, you know, one of the things that's really important, and I'm a surgeon, but you know, the other doctors and nurses and specialists involved in the treatment are really important, more important than me, because making sure the child is generally well, has good general health, things like looking at the blood count, anemia, looking at other medical problems. As you know, many children in Moyamoya may have other medical conditions, looking at the heart to make sure there's no structural problems with the heart, looking at blood pressure, which I'll talk a little bit more about. All that needs to be looked at before you think about an operation. You need to have as much information, and you need to optimize, you need to treat that child in such a way that they're as well as they can be when it comes to the time for surgery. There are things that us as surgeons can do. I'm going to tell you a little secret, brain surgery isn't that difficult really. And actually many surgeons have the technical expertise to do these operations, but I think what makes the difference really is this last point, the wider team. If you have a team around you as a surgeon that are familiar with Moyamoya disease, the disease itself and the operations, and know what can happen, the good outcomes, and also the things that can sometimes be bumps on the road, and know how to deal with those, that makes all the difference. If you're in a situation where people don't, many of you families will have experienced this, going to a hospital where the doctors are looking at what Moyamoya is on Wikipedia, you know you're going to be in for a slightly different experience. And I think really that is the number one thing that I recommend. Choose a high volume center. You know, Dr. Smith, who's going to be talking later, and a friend and colleague of mine, published this nice paper looking at outcomes in centers where they only do one or two of these operations versus centers where they're doing large numbers of operations. And in pretty much all the metrics measured, it's better to be in a bigger center. But even with a bigger center, remember, it's a rare disease. In this paper, the bigger centers had a median admissions, not even operations, but admissions from around 19. So, you know, it's never going to be a condition like a hip replacement or something else where people are doing hundreds of these a year. But if people are doing, you know, 5, 10, 15, 20, we're doing often 25, 30 cases at Great Ormond Street every year, then, you know, you're into a very big center. This is our own experience. My hospital doesn't look like this yet. It's going to look like this soon. This is an AI image of what it's going to look like once all the refurbishment is done. These are figures from our pediatric neurosurgical group in the UK, and this shows the number of neurovascular procedures, most of which in our centre of Moyamoya and AVM surgery in children in 2023. All of these bars represent a neurosurgical unit in the UK. I've blanked out the names to save any blushes, but you can see that Great Ormond Street has, you know, doing over double the next biggest centre. And I'm not showing you this to show off, because I didn't do all of these procedures. Some of them were done by my colleague, Mr. Silva, you've heard from, and also from, you know, some of them were done combined or whatever. But I think what's really important is that it means that the nurses I work with, specialists I work with, have seen children with this neurovascular disease like Moyamoya. They see them all the time. They know what it means. When a kid comes to the ward of Moyamoya, everyone knows what it means. They need to have fluids. You need to have aspirin. You need to look after them. You need to watch them very carefully. If you're in this centre here that did one neurovascular procedure in the whole of 2023, the staff are just not going to have that experience. And like I said, I don't think it's anything to do with surgery or skill. You know, all of these centres are very skillful neurosurgeons, but the difference is that caseload. Your radiologists know what scans to do. Your anaesthetists know how to anaesthetise children on Moyamoya. This is really what it boils down to, that multidisciplinary assessment and working. You know, it's not just about your neurosurgeon, it's about the paediatric neurologists, it's about the nurses, it's about the radiologists, it's about your EEG doctors and technicians, it's about all these specialists that come together. And if you have a critical mass of experience with a condition, that helps at all of these stages, the preoperative, workup, assessment, communication is really important, telling families what is going to happen in children, what to expect. the operation itself, which of course as a surgeon I'm very interested in, but isn't just about the surgery, it's about the preparation, the anesthesia and the post-operative care. And then finally, what happens after the operation and after you leave the hospital? You know, do you have a follow-up program to support children with Moyamoya? It's really important to have a detailed preoperative workup. And, you know, we're very lucky to have 3 very experienced pediatric neurologists on our neurovascular team, Dr. Deaconess and Dr. Beth, Dr. Ulwis, who I see all the patients with and who help to work up and look for those things that sometimes as surgeons, because we're focused on the scans and the operation, we may miss. You know, genetic factors are increasingly recognized as being important in Moyamoya. Other conditions are critical, neurofibromatosis, sickle cell, those need to be managed by the appropriate specialists. And again, a big children's hospital like Great Ormond Street, we're lucky to have the specialists who can help with that. I'm kind of obsessed with blood pressure. I really want to know what my patient's blood pressure is when they're well, so we can try and keep it like that. Making sure they're on the correct medication. Sometimes patients will come on medication that they don't need to be on, particularly going back to blood pressure. Children with Moyamoya often need a little bit of a higher blood pressure. Sometimes that can cause worry and people try and drop the blood pressure down, but that's often the wrong thing to do. Understanding how to keep kids well hydrated, and our nursing team do a great work with the schools and the local paediatricians to make sure everyone's educated in knowing that children with Moyamoya need to have their water bottle with them at all times. Do they need to have a peg? Do they need to have a line to let them have water? And having a really good imaging set up in terms of MRI scan, angiograms, and other specialist imaging that you need. And again, in the critical mass in a big centre, you have access to those. They always say that the most important person in the room during an operation is the patient, and the second is the anaesthetist or surgeons are somewhere down at the bottom. It's your anaesthetist really who's going to keep your child safe during the operation, or anesthesiologist, as you call them, if you're from the States or Canada. And, you know, again, it's about experience. So these anaesthetists have their anaesthetized children with Moyamoya. Do they know you need to keep the blood pressure in a certain range? What kind of monitoring techniques are we going to use, particularly monitoring of the brain with EEG or BIS or other mechanisms? Most importantly, you know, I do Moyamoya surgery all the time. 9 times out of 10, it's very straightforward. But on that day where the blood pressure drops or there's an unexpected change in the EEG, does your anaesthetist know how to respond to that in a safe and timely manner? There are surgical nuances. I've tried to downplay the importance of surgery, but I think the importance of a high volume centre is you learn about different techniques. You know, you understand that there are different ways of achieving revascularization and in Moyamoya surgery. I'm not going to go through all of that because I think there are some other talks about that, but it's important that your surgeon knows about those different techniques and knows which ones to use for which patients. That's very relevant to the different conditions that children have. So a child with sickle cell or a child with neurofibromatosis often has a slightly different anatomy, a different way of thinking about things in terms of the surgery. And again, just by doing lots of cases, you get that experience. And really, it's about the communication, working with your colleagues in anesthesiology or EEG team or nurses. And if you're doing that all the time with the same team, that really helps. Nursing is utterly critical. We're very lucky to have 2 dedicated neurovascular nurses, Claire Toulis and Rachel Derling. But our whole wider nursing team, our neurosurgery nurse practitioners, our ward nurses, our ICU nurses, our theatre and scrub nurses and anaesthetic nurses are absolutely critical to the safe care of children with Moyamoya disease. They have a really important role in communication. Although I think I'm a nice guy, I always know that when the families leave the room, they always have some questions sometimes that they think might not be important enough or relevant enough to ask a professor or a neurosurgeon, but these are important questions and our nurses deal with them all the time. They're with the families all the way through, from preoperative to postoperative. They get to know the families over years. And again, they're there when things happen. Something's happened at school, someone's had a new symptom, a new headache or a problem with the wound. It's our nurses who are there to respond to that and deal with that. And that communication in the family, the nurse and the surgeon is really, really critical. So where are things going? So, I mean, certainly at Great Ormond Street, and this is how our front entrance used to look until it was recently demolished. What are some of the things? So some of these things, some centres we're using already, but some of them are things that we've begun to introduce over the last few years, myself and my colleague, Mr. Silva. Increasingly, we're using EEG monitoring during surgery, so measuring the brain waves during the operation to see if the brain is happy. If there are signs that the brain isn't getting enough blood, there are features on the brain waves that we can see, and then we can do things to try and rectify that with giving more fluids, driving the blood pressure up, giving medication to relax the brain. When I learned Moyamoya surgery from my mentor, Dr. Thompson, he always used to do bilateral surgery in stages. So he'd do one operation, as I always say to kids, you're lucky you only got 2 sides. I can't do 3 sides. So the first side is done as one operation, and then the second side is a separate operation. Traditionally, that was done as 2 separate visits to the hospital, often 6 or 8 weeks apart. Increasingly, I think it's better to try and do both at the same time, if both are needed. Not all kids need both sides doing. And doing that under the same anaesthetic using monitoring, I think, is very safe and effective. I told you I'm kind of obsessed with blood pressure, and our nurses really are leading this, getting ambulatory blood pressure, so using a cuff to see how kids' blood pressure are when they're well. As doctors and nurses, we're often seeing blood pressure measurements under anaesthesia, or patients are in the hospital, they may be stressed or in pain. But what's your blood pressure? What's your kids' blood pressure doing when they're at school, when they're at home? That's really useful, because then we know what we need to achieve during surgery to protect the brain. And it's something that I think is going to be increasingly important, is understanding the blood pressure dynamics of these children. Aspirin thins the blood, so many surgeons like aspirin to be stopped before surgery. And again, my mentor, Dominic Thompson, used to stop the aspirin 10 days before the operation. But we've learned, and I think experience in other units, and certainly with us, is that it's very safe to carry on with the aspirin during the perioperative period, and it's probably beneficial, and that improves the blood flow. And the bleeding, we don't seem to see any bleeding complications with that. And again, talking about hydration, getting an IV in a kid can be difficult. They can be pulled out. So, do you need to do a PICC line, a tunneled line, or a PEG before admission to try and make sure that you can keep kids hydrated, even if they're a little bit wild and pull things out. Last thing is really how important it is, and that's why I was really delighted to be invited today, because I think the Moyamoya Foundation are doing an amazing job. And I think, as doctors, we learn so much from each other, and with a rare disease, pooling that experience is important. There's the International Pediatric Stroke Organization, which is a really wonderful organization of doctors and nurses interested in stroke in children, including Moyamoya, and our collaboration with Boston and Sick Kids in Toronto, which I think has been really, really rewarding, not just for us as doctors and nurses, but really had actually added value for our patients. Finally, this is absolutely not a one-man band. This is the team at Great Ormond Street. These are just the core members of the team. So these are the main neurovascular people, I guess, our neurologists, our neurosurgeons, our radiologists, and our nurses. But there's a whole wider team around that: renal physicians, dermatologists, cardiologists, nurses in different areas of the hospital, geneticists, and really without the support and help of the rest of the team, really Moyamoya surgery isn't possible. So hopefully that gave you an idea of why I care so much about making Moyamoya surgery safe, and some of the steps we've taken at Great Ormond Street to make Moyamoya surgery safer and safer. And I think we've got some data to show that it is getting safer. And I really hope you enjoy the talks from my other colleagues, who I'm sure will be giving you some really interesting insights. As I said, if any of you want to reach out to me directly, you can contact Catherine. I'm sure I'm very happy to share my contact details if anyone's interested in learning more or talking to me about any other things I've said in this talk. Have a great day, and thank you again for inviting me.
Thank you very much to Mr. James for sending us that informative and educational recording. Very, very important to talk about. So thank you. I am now pleased to introduce you to our next speaker, Dr. Laura Lehman, she is a pediatric neurologist at Boston Children's Hospital. She has a special interest in cardiovascular disorders, stroke, and neurocritical care. She is currently involved in the inpatient intensive care neurology service, inpatient and outpatient for the Stroke and Cerebrovascular Center, and outpatient general neurology clinics. She serves as the outpatient medical director for the Stroke and Cerebrovascular Center that focuses on a multidisciplinary approach to optimize diagnosis and treatment. Dr. Lehman's current research also focuses on cerebrovascular disorders and stroke with specific focus on risk factors in both perinatal and childhood stroke and emotional outcomes of parents and children following pediatric stroke. We are thrilled to have you here today, Dr. Lehman, and we look forward to hearing her presentation, Asymptomatic Moyamoya.
Thank you for that introduction. It's an honor to be here. Let me share screen here. So I think that these talks are all exciting. And for me, something that I think is hard is asymptomatic moyamoya. And how do we treat patients that don't have symptoms yet, but are found because of other reasons, whether it's an MRI that was done or they have a known syndrome where moyamoya is associated with it. So I'm not going to talk too much about moyamoya, since I think all of you know what moyamoya is as a progressive cerebrovascular disorder. And we know that it has a high risk of stroke. And patients present with other symptoms, though, that aren't stroke, including transient ischemic attacks, seizure, movement disorders such as chorea, headaches. And then there's this growing population of patients that don't have symptoms when they're diagnosed and have an MRI for another reason. So as a neurologist, I feel like my role is integral. I don't do the surgeries, though, of course, and that's the most important treatment for moyamoya. But we do neurological exams and evaluations and follow the children from initial diagnosis all the way through to follow-up post-op. We try and help with stroke prevention and treatment, and then we treat the symptoms that are going along with moyamoya, such as headaches and seizures. And then we're also assisting with monitoring patients for progression. And sometimes that can be silent progression. So asymptomatic moyamoya is still moyamoya, and it's being diagnosed more frequently prior to the development of symptoms, partially because we get more MRIs these days. They're much more accessible. And then they can also be done because there's a known association with a disorder such as neurofibromatosis type 1, sickle cell anemia, FACES, trisomy 21, and morning glory disc anomaly. And I'm sure there are many others, of course. But there is this controversy of when or if to revascularize children who do not have symptoms related to their moyamoya. When are they far enough along that they would benefit from revascularization surgery? When I think of asymptomatic moyamoya, I don't think of just patients that are presenting initially and don't have symptoms, but what about the progression of other arteries that may not have any symptoms as they progress? Up to 40% of children with moyamoya will have posterior cerebral artery involvement, which is in the back of the head, and that doesn't always come with symptoms as it progresses. There's also, as you've heard, anterior cerebral artery stenosis that can progress as well. And sometimes that will present with TIAs or stroke, but it's good to catch it before symptoms arise. As we know, revascularization surgery, especially the first revascularization surgery, it focuses mainly on the middle cerebral artery territory. And so the question is when or if to perform revascularization surgery to protect the ACA or PCA is a question of interest to me. Another thing that I think is important is how do we screen? So it's hard to screen for moyamoya when there's only a small percentage of children who will develop the disorder and may not have symptoms at that point. And some of these patients, why can't we just get MRIs on everybody and screen that way? It requires sedation in children less than the age of 5. And in older children, if they have learning difficulties or autism, MRI is not necessarily an easy thing to get without sedation. So something that I think is interesting is if we could have a non-invasive way to screen children with syndromes such as trisomy 21, sickle cell anemia, neurofibromatosis type 1, that wouldn't require sedation. And so one thing that's out there that is being researched, it's not used as a screening mechanism yet, is transcranial Dopplers, which is an ultrasound that you can put on the head and then see how the flow from the arteries is doing. It's non-invasive. There's no sedation required. Children can tolerate this well. And so there is a study out there looking at neurofibromatosis type 1. They screened 40 children with TCDs, and they flagged 4 children that had concerning findings on the TCDs. And out of those, 3 had MRAs that were confirmed a diagnosis of moyamoya. So there is potential there. Bigger studies are needed, multi-center studies are needed, but there is that potential of using something non-invasive to initially diagnose patients with moyamoya early on. And why would you want to diagnose patients early on? I think that's the key, is when is the best time to revascularize patients? Is it early before they have symptoms, or is it after they develop symptoms. And so the ways that we monitor patients include whether they develop symptoms. So over time, does an asymptomatic patient develop a TIA or a stroke, or hopefully not a stroke, but seizure, headache, chorea? And we do serial MRIs to try and figure out, before the child would have any sort of injury on MRI, when would be the best time to revascularize. Some of the techniques that are out there used for both clinical as well as research include perfusion imaging. There are many different types of ways to look at how blood supply is getting to the brain through the collaterals when the larger arteries are becoming smaller over time. There's also the cerebral catheter angiogram, which is important on many aspects, not only for diagnosis, but for surgical planning. And something that I do research in is diffusion magnetic resonance imaging. Is there a way to find a biomarker that would let you know when is a good time for a child to undergo surgery, and how could you follow them long-term? So what I wanted to briefly show is when we're talking about the arterial territories that we're following, whether it's I like these pictures. I like colors too, if you can't tell from the images. But the anterior cerebral artery territory, you can see right here in this area is in the front of the brain. And then the middle cerebral artery territory covers the majority of the brain. And then the posterior cerebral artery territory is in the back. And this is, I'm sure you've probably seen MRAs before, but this just kind of helps to show where those arteries are in a child. So this is the front of the head where the anterior cerebral arteries are. The middle cerebral arteries are over here, and the posterior cerebral arteries are back here. So something that I was excited to hear is that the hungry brain has already been mentioned. So the hungry brain is a concept where, when is the brain not getting enough blood supply, that also when you revascularize the patient, the blood supply will grow, because the growth factors are there to send signals to have this blood supply grow. And when is the best time for this brain to get that blood supply that it needs? So one of the ways that I've been interested in looking at both the hungry brain and following patients with Moyamoya is using diffusion magnetic resonance imaging, otherwise known as DMRI. And we specifically look at the white matter of the brain, because there are many tracts throughout the brain. And that's part of the importance of understanding cognition is understanding what the tracts are doing and where they're going and how they're commuting from a part of the brain to the other. So for the last 4 years, we've been using diffusion MRI in children with Moyamoya. And so to talk about diffusion MRI, I think it's good to start with the neuron. So the neuron is the basic cell that starts out for all the different neurons that are in your body that make up the brain. So the neuron has this cell body and then the axon here. The cell body is the gray matter, and then the axon makes up the white matter, or the white matter tracts. So a group of these axons that are in this cell make up a white matter tract. And when you're looking at an MRI, the white matter is on the inside, as you can see here, and then the gray matter, which is the cell bodies, are on the outside. And what we can do with diffusion magnetic resonance imaging is to isolate those white matter tracts that go from different parts of the brain. And then they also are talking to different parts of the brain. So it's an important way to look at the brain and how it functions, as well as the blood supply. And I'll get into how that happens the next couple slides. But you can see here, there are ones that are come like directly down. This is the cortical spinal tract. It does motor. And then this is a corpus callosum. I think of it as like talking from the right hemisphere to the left hemisphere. It's midline. And then you have all these other white matter tracts that are also crossing an area that I think is concerning, which is this watershed region. So the watershed region is the area between these arterial territories, both MCA, ACA, and MCA, PCA. So those arteries have an area where there's decreased blood supply, especially in the case of Moyamoya. And what we looked at was the white matter tracts in that watershed region. So we took all the white matter tracts that were in this watershed region, we pulled them together to try and make a biomarker to understand whether children with Moyamoya were being hypoperfused and was it affecting their white matter. And so we looked at these children all before surgery, and we found out that they do have different white matter compared to children that don't have Moyamoya. And that could be maybe a marker to show that they're having white matter hypoperfusion. So The thought with this is could we use this as a marker and follow it for children with asymptomatic Moyamoya to understand better when is the best time to revascularize children? And then could we also use it in patients where having progression of the anterior cerebral artery or the posterior cerebral artery to determine when would be the best time for revascularization surgery? And this is just in the preliminary stages. We have grants that are coming out to try and understand this more. And so I think the other thing that you've been hearing a lot about that I'm very excited is this collaboration. So with a rare disease, it is so important to have collaborations, not just as we talk about with like the Boston, London, Toronto group, which is amazing, the International Pediatric Stroke Organization, which is a great organization too, and International Pediatric Stroke Study, all ways to work together from multi-different hospitals throughout the US, North America, but also the world. And what I think is also even more important is the patient advocacy groups, specifically the Moyamoya Foundation, who is bringing all of us together to talk about this, but also to help with thinking about what are the research questions that are most important to patients and their caregivers. So up to 6% of childhood stroke we know also is due to Moyamoya. But in order to really understand this, we need the power of these large multidisciplinary groups. And we're trying to leverage to jumpstart some great grants and some great research. And we are starting to work both with the Moyamoya Foundation as well as with the International Pediatric Stroke Study so that we can have registries to better understand the natural history of Moyamoya, not just at one place, which is how the studies have been published, mostly is from one site, but to understand how it is throughout multiple different sites. And my interest, of course, is to understand asymptomatic Moyamoya so that we can understand when is the right time to treat patients who don't have symptoms, because I think that we're going to find more and more if we're screening patients that we're going to find it before there are symptoms. So lastly, I wanted to thank the Boston Children's Group for all of their support. As you can see here, Dr. Smith, Dr. C, Dr. Orbach, our wonderful nurse practitioners, Chris Isabor and Jennifer Judge, and Connor, one of the coordinators. They all make up the team. And I think as you've heard tonight, the team is so important for treating patients and for having good outcomes. So thank you.
Thank you so much, Dr. Lehman. We're very appreciative of you being here. And personally, the hungry brain is something new to me. So I'm very interested in hearing about that, and I'm sure others are as well. So thank you again. I'd now like to take a moment to acknowledge one of our scheduled speakers, Dr. Edward Smith. Unfortunately, due to sudden unforeseen circumstances, Dr. Smith is not able to join us tonight. For those of you who do not know him, Dr. Smith is the R. Michael Scott Chair in Neurosurgery at Boston Children's Hospital and the co-director of the Cerebrovascular Surgery and Intervention Center, affiliated with Harvard Medical School. Dr. Smith is a great partner to our foundation, as well as to pediatric Moyamoya patients. So we are disappointed he is not here tonight, but he has promised us that he will be able to give us his presentation at a later date. So we hope all is well, and we miss having him here tonight. I would now like to let you know that we are going to be taking a brief 15-minute intermission. We are planning this before we go to the next 4 speakers. So take a moment, get a drink, you can have a snack, and we will continue in 15 minutes with our next speaker, Dr. Ogilvy. Thank you.
Hello, everyone, and welcome back to this session. Our next speaker that we have for the evening is Dr. Christopher Ogilvy. He's the director of the Endovascular and Operative Neurovascular Surgery Program at Beth Israel Deaconess Medical Center for their Brain Aneurysm Institute. He's also a professor of neurosurgery at Harvard Medical School. In the laboratory, Dr. Ogilvy has focused on studying cerebral ischemia in the setting of neurovascular procedures, with a recent focus on the biology of intracranial aneurysms and the use of tissue engineering techniques to treat saccular intracranial aneurysms. He has pioneered several techniques in surgical procedures and is pursuing avenues of research in clinical treatment of patients with intracranial avascular problems using endovascular techniques. Today, Dr. Ogilvy will be presenting on vessel response to indirect bypass in adult Moyamoya. Thank you.
Thanks very much. I think I need my video started. There we go. And share screen. Thank you. Thanks very much. I really appreciate the opportunity to be here. I appreciate the foundation allowing us to help support their efforts on a regular basis, and I've really enjoyed working with the foundation as it's got up and running. This is a really growingly recognized problem for adults, and I'm going to make some comments about adult Moyamoya disease and then some work we've been doing on response to some of the procedures we do in adults. And I realize it's a little difficult because the audience is everywhere from world experts in Moyamoya disease to maybe some people who are just learning about it for the first time or just made the diagnosis. And that's where I come into play with the adults that have this. And I was at Massachusetts General Hospital for 20 years, and I've been at Beth Israel Deaconess Medical Center for 10, both Harvard hospitals. And at the Mass General Hospital, I treated children and adults, and the Beth Israel has a neonatal ICU, and then the rest of the hospital is just for adults. However, conveniently, we're about a block and a half away from the Children's Hospital in Boston. Dr. Ed Smith and Alfred C., as well as others, are great colleagues. And when children turn 18 in many children's hospitals, they go elsewhere for their care to adult hospitals, which is where we come in, because we often transition their care for Moyamoya patients to our center. And we have actually established an adult Moyamoya Center of Excellence with a team, as you've heard, with neurologists, neurosurgeons, radiologists, and it's extremely helpful in managing these patients. And the adults do have some different caveats to the syndrome or the disease than children. And you've heard a lot about children's from some of the world experts in the disease. So I'm going to maybe direct my comments a little more to adults, although many of the comments you've heard so far apply to adults and children. Here are my disclosures, which none are relevant to this presentation. Just a couple of basics. I think most people on the line know that the Moyamoya is the diagnosis. It's really the name of the disease is based on what the angiogram, a diagnostic test, looks like, which is probably one of the weirder things in medicine. And as you all know, it's a puff of smoke on a cerebral angiogram because the person who named it was a Japanese neurosurgeon who actually smoked cigarettes, and he looked at his cigarette smoke and looked at the angiogram and said, those look a lot alike. So that's how we got the name. Ed Smith and I do like to say that it's a disease so good you have to say it twice. But for patients and families, especially young adults where the diagnosis is made, the puff of smoke can really be a house of fire. Because here's someone who previously was either completely normal, no other medical issues in many situations, who all of a sudden now has a stroke or a neurologic event at the age of 20 or 30 or 40. And we've seen this even up into the 50s and a little beyond. A little different than in kids, when you see a narrowing of the vessel in an adult, it can be Moyamoya, and that's what we deal with. It can also be atherosclerotic disease or hardening of the artery, which is a completely different disease. The acronym for that is ICAD, or intracranial atherosclerosis. And this is very different than Moyamoya. And in the adults, we sometimes spend time trying to figure out, is this Moyamoya disease in an adult, or is this atherosclerotic disease in a person who's predisposed to that? Maybe they have risk factors of smoking and diabetes and other things that cause hardening of the arteries. But you see in this background slide, the second point here says non-atherosclerotic progressive steno-occlusive arteriopathy. A lot of big, nice words. But basically what it means is the vessel wall gets thicker and thicker, and as a result, the vessel lumen gets narrower and narrower. And in response, you see this sprouting of blood vessels into the brain. And that's what gives this so-called Moya pattern or Moyamoya pattern. And there are degrees of this, as I'll show you. These show the different stages of Moyamoya disease, and it's graded based on this so-called how much the occlusion, how bad the occlusion is, and how much the response of the brain has made to this. You see here, there's this fuzz on the lower left-hand corner. Those are the Moya vessels sprouting to try to give the brain more blood flow, we think. And these are tiny vessels and they're fragile. And in adults, as in kids, they can show up because one of those fragile vessels breaks. And instead of getting a stroke from low blood flow, you get a stroke because there's a hemorrhage or a blood clot. And when the vessels do narrow at the base of the brain, this produces what have you've heard already, the so-called hungry brain. It would mean hungry for oxygen. The brain, is striving to get more oxygen, we think. And it's amazing that in Moyamoya disease, our treatments, our surgical treatments, are actually based on the patient's response to the biology of what's going on. Because just like they try to sprout vessels on their own, if we can give a vessel to the brain, that is from the outside of the head, and you've heard of the so-called indirect or direct bypass, and I'll just briefly go through that because Mr. Silva and Mr. James already sort of detailed that. But if you can supply that, the patient has the biology to then sprout blood vessels and help vascularize the brain. And I'll show you some of the work we're doing to try to guess who is going to best sprout vessels and who isn't, because we don't really know that at this point. But basically, if you look under the microscope at these narrowing blood vessels, you can see that the blood vessel wall is sort of heaped up and there's fibrosis in the wall itself, which causes this narrowing. And there's no atherosclerosis here. It's just the muscle wall getting thicker and thicker over time. And that progressive narrowing is what produces the pattern that we see on the angiogram shown here on these pictures, where you see these wild sprouting of blood vessels and causing this so-called Moyamoya picture. It's a little more prominent it is more prominent in Asians. However, virtually any subpopulation of individuals can get this. And we see it's more prominent in Asian Americans. And you see the numbers on the bottom in African Americans, whites, and Hispanics. But more and more, we are making the diagnosis in young adults throughout the country who don't have any of these risk factors. And I get calls really since we established our center, not only all over New England, but all over the country, where young individuals, some because of the internet, are making their own diagnosis. In some areas of the country, stroke, the neurologists are not specialists in stroke, haven't seen it a lot or ever, have read about it, but really they get a young individual with a stroke and they haven't worked it out that it's Moyamoya, and they send their films or they tell me their story. And I said, gee, you've got Moyamoya. And that is something they had not heard before. So this is very important to recognize. It is still, because of these low prevalences, a rare disease, but it's an important disease, as everyone on this call knows. And there's a lot of thinking about what the mechanism of what's going wrong is. And the reason there's a lot of research in this area is because that's how we're trying to define what we might do besides surgery to make it better or to help in terms of blood flow. Now, adult Moyamoya disease is a significant cause of stroke in young adults, in 20 to 30-year-olds. There's a number of things that can give young adults stroke. You heard Laura Lehman talk about children and the various causes of stroke that can occur, as did Liza from Toronto. But the Moyamoya really pushed us to form an adult Moyamoya center where we bring together the neurologists, the neurosurgeons, radiologists, in order to study and treat patients with this problem, as well as establish long-term care for them. The diagnostic criteria you have all heard, where there's narrowing of the larger blood vessels in the brain and then sprouting of the smaller vessels in the brain, giving the so-called Moyamoya pattern. There's no real medical regimen that's been proven to be effective in Moya patients. Many of them end up on antiplatelet therapy, as you've heard, with aspirin. We think that may carry with it some benefit. Anticoagulation really is not generally recommended because of the risk of hemorrhagic stroke in these individuals and the fact that it hasn't been demonstrated to have a huge efficacy. Surgical management, as mentioned by Mr. James and Mr. Silva, definitely works. But a key piece of it is having the team where we, during surgery, do a lot of things we don't do for other types of brain surgery. We want the brain to shrink. We want so we can use microscopes to move around the base of the brain. In this situation, we want meticulous blood pressure control, no brain relaxation, and keep the brain well perfused, that is, keeping the blood pressure up, as you heard. People are very almost obsessive about blood pressure, as they should be in this situation, because it's so important. This, you've seen some of the other cartoons about what can be done about this, a direct bypass where we take a vessel from outside of the head, usually the superficial temporal artery where you can feel your pulse if you put your finger in front of your ear, cut that and suture it to the brain, to the blood vessel inside the brain, the middle cerebral artery. And then there's a so-called indirect where we lay the blood vessel on the brain surface. And again, if you did this in a patient who had a stroke from a clot going to the brain, clogging off the blood vessel, or from atherosclerosis, you don't see much of a response at all, if any. But in a Moyamoya patient, you see great development of collaterals, as I'll show you. Let me just get through this. This is just a picture of a CT angiogram of the superficial temporal artery. And this is what we've looked at in patients with Moyamoya before and after our surgical procedures. And I'll show you that indeed this has the ability to get bigger over time in a very useful way for patients with Moyamoya disease. This is what it looks like under the microscope after it's dissected out. And we usually leave a fair amount of tissue on it. You get, I'll show you some of the acronyms of the procedures we do. We sometimes just put the vessel on the surface. Sometimes we put muscle on the surface as well. All of these things have been found somewhat empirically. That is, it was done and a good response was found. And therefore, we continue to do it or variations of it. And this just shows a typical, this is the blood vessel inside the brain, the middle cerebral artery. And here we are bringing in that superficial temporal artery where we clean the end of it, leaving the fat and tissue around it so it doesn't injure the vessel, and then go ahead and suturing this together. And by placing these sutures now, we establish this new blood flow into the brain because the carotid artery has been blocked off. Now, interestingly, here's an adult, this was a fireman who had a brain hemorrhage. And in investigation, he was found to have Moyamoya. And as most of you know, in adults and in kids, they can not only show up as a stroke, but as a so-called hemorrhagic stroke, or here on this scan, the white blob is a blood clot. So he had a hemorrhage. And he was having a very tough time with his cognition. And this was actually in an era where it hadn't been proven that the bypass procedure, so you say, if it's a stroke and they're not getting enough blood flow and we bring new blood vessel in, that's going to make them better. That seems to make sense. But actually what's been shown is that patients with hemorrhagic Moyamoya disease, that is if they have a hematoma, blood clot, and you do a bypass procedure, it actually is beneficial as well. And this individual really brought it home to me because I bypassed him, and you can see here now this superficial temporal artery is connected to his middle cerebral artery. He had immediately better blood flow. And within about 3 weeks, he came back to the office and says, I don't know what you did, but I'm feeling better. I'm thinking better. He said his cognition was better, and he remained that way. So this really impressed me. And if you look statistically, the chance of another hemorrhage drops when you do this procedure. So these are patients that we do the direct bypass in. Now, there's a number of patients, and this is his angiogram a year after the bypass, there's been good ingrowth and good flow to that hemisphere. Now, the indirect bypass, where we put things on the brain surface, here are just a bunch of names that all these initials you hear are usually initialing what we're taking and putting on the brain surface. EMAS, where you take a piece of myo or muscle, EDAS, which is encephaloduro arteriosyngangiosis, big long words, and that's where we take the artery and suture it to the surface of the brain and allow the blood vessels to come on and sprout and grow to the brain over time. That takes time for that to happen. And here's just one of these indirect procedures where the artery is dissected free. This is the dura mater, literally tough mother, being opened up. And then we lay the vessel on the brain surface and can suture it to the pia arachnoid, which is this shiny surface here. And in so doing, then it stays in continuity. So there's still blood flowing through this. And once it's in position, over time, blood vessels can sprout to the normal brain from this. And this just shows what it looks like. I'm not going to drag you through a video of what it looks like, but I will show you that over time, new blood vessels can sprout from this vessel placed on the surface. So this is 1 year after this procedure, and all of these vessels are new. they've grown from this extracranial vessel to the vessel on the surface of the brain and started to give the brain more blood flow. You can see it's been done on the left side here with these little screws in the bone. Now, one thing we've studied in more detail, and you saw one picture of it from Mr. Silva. There actually was a surgeon in France who described just putting multiple burr holes in. So what we do is this one procedure where we lay the artery on the surface, and then we put two burr holes in. And we studied these patients because we found that in some of the patients, the burr holes had better ingrowth than other areas. And this red circle shows an area 1 year after this procedure was done, where we just placed a burr hole up in this area, burr hole being a hole of the skull about the size of your thumb. And just by providing that conduit, blood vessels can grow to the brain surface and bring in new blood flow. And as was mentioned by Mr. James, statistically, when you look at these patients and do a procedure, whether it's this direct or indirect bypass, the number of events they have, the strokes, the TI, what are called transient ischemic attacks, drop down in number or go away completely over time. And if you do a bypass, it sometimes happens immediately. But this just shows the kind of ingrowth. This before the top panel, this was when we met the patient, this is what their angiogram looked like. And this is a year later after providing these conduits for blood vessels to grow. And this is simply the burr hole. This was the EDAS, or the onlay part of the procedure. And you can see that vessels sprout out and grow to the brain surface. And so surgery is indeed effective treatment. I won't drag you through the numbers, but I'll show you these graphs because they're pretty easy to understand and obvious. And what this shows is that the number of events per year, or TIA or stroke, in patients who didn't get surgery, which is the dashed line here, they had many more per year than patients who did get surgery. And this has been shown in a number of studies, large numbers of patients, well-conducted studies where this has been the case. Now, we've asked the question, what happens to these vessels over time? And can you predict who's going to respond well and not? Now, we haven't worked all of that out yet. We're working on that right now. By looking at the preoperative images, can we predict who's going to respond better to one of these techniques or the other? And we don't know that answer absolutely. What we do know is this, and I'm going to cut to the chase here, that here's measuring this superficial temporal artery, the vessel outside the head. And we made this measurement before they had the procedure done. And a year later, we did an angiogram and made the measurement again. And it's in a small number of patients, only 27 patients, 35 hemispheres. Realize each patient, some of them get each side done, as was mentioned earlier by a number of the physicians. And the demographics of this is pretty standard for an adult population with Moyamoya, a little more female than male. And we looked at some of the other issues going on in terms of other medical issues that they had. But what we found, I won't drag you through this, I'll just show you a pretty simple graph, which is that when we looked at the size of these vessels, it increased dramatically from placement to 1 year later. So this is the size of the vessel average with a standard error before the procedure, and this was the size of the vessel afterwards. So actually, in a Moyamoya patients, they have the ability not only to grow more blood vessels, but that probably increases the flow through this vessel. And in response to that, actually, instead of shrinking, the vessel actually enlarges, allowing more flow. And I've even done this procedure where the vessel we put on the surface looks pretty tiny at the time of surgery, pretty small, and a year later it looks robust, bringing flow to the brain. And the patient's done well clinically. Their spells stop or go away. They've lived, they get back to normal life, normal exercise. There are criteria for that, of course. We want patients to stay well hydrated, blood pressure maintenance, letting the blood pressure run even maybe a little high for normal. These are things we work with general physicians and neurologists to help maintain after the procedure. And here's just an example of what we're talking about. Here's what the patient's blood superficial temporal artery. This is an injection looking at that blood vessel on the outside of the skull before the procedure. And here, same patient, same vessel. See that branch point? That's that branch point. And you can see, although we know the scale exactly on this, but you can see it's much more robust after the procedure. And look what's gone here. There's been vascularization of the brain underneath. not only in the area of the so-called EDAS, but also in the area of the burr hole. And we think this is a demonstration of the so-called starved brain. That is, this is a brain that needs and wants oxygen. And in you patients with Moyamoya have the right factors to allow this sprouting to occur. We did find some other features that hyperlipidemia was negatively associated with this collateral development. That is, they didn't have the good response when they're hyperlipidemic. We worked pretty hard to control glucose, lipids, and blood pressure in these patients, but let the blood pressure sometimes ride up a bit. So I will finish here and just conclude with the statement that Moyamoya is increasingly recognized as a cause of stroke and hemorrhage in young adults, thankfully. Proper treatment is indeed available. It's being studied pretty intensely to see if there might be some non-surgical treatments. We're doing some metabolic studies as well. And as for patients, or I should say, it really is helpful to have a team to manage these patients, as you've heard from some of the other speakers. Because it really helps not only in the pre-op evaluation and discussions, but also intraoperatively and after treatment is probably the most important thing. As I say, we sometimes take over the care of the 18 to 20-year-olds when they've been bypassed maybe 10 or 15 years earlier, had surgery at Children's earlier, and that way it maintains a continuity of their care. We can communicate back and forth. They can stay in touch with their original physicians. And it really is quite a nice thing for them and their families. So I'll stop there. Thank you for your attention and been very much enjoying this evening's symposium. And thanks for the opportunity to be here.
Thank you so much, Dr. Ogilvy, for such a wonderful talk. Our next speaker is Dr. Timothy Lukovits, a vascular neurosurgery or neurology specialist and the medical director of the Cerebrovascular Disease and Stroke Program at Dartmouth Health. He is also an associate professor of neurology at Dartmouth Geisel School of Medicine. He has over 30 years of experience in the medical field. He graduated from the University of Rochester and subsequently completed a neurology residency at Dartmouth and a cerebrovascular fellowship at Rush Presbyterian St. Luke's Medical Center in Chicago. Today, he will be sharing headache and other medical issues with Moyamoya.
Great, thank you. And I'm glad to be participating with such an excellent group today. So, you know, some of these topics are somewhat may seem a little mundane compared to what you've been hearing about, but I think for the people who experience these, they're far from mundane. But it'll be a little change of pace here because I'm going to talk about some secondary issues that surgery may not fix. And I'm going to highlight headaches and talk a little bit about seizures. And there's other things that have challenges and require special attention for people who have stroke, and especially at a young age, that I won't get to today. Since I spoke one of the other years, there's been some new literature that fortunately is starting to focus on the particular issues with Moyamoya compared to other patients with stroke in general. And previously, I showed that there was one sort of section in the American Stroke Association guideline from 21 that talks about Moyamoya disease, but basically there's very little evidence, as was mentioned, for the role medications might play in directly preventing stroke or the disease itself. So there's basically a summary that often patients are on antiplatelet medications like aspirin, and these numbers and letters indicate that it's not a very high level of evidence. So that's, you know, some updates have occurred just last October. There was an American Heart Association scientific statement that came out that also is a good reference for both the surgical and medical treatment of Moyamoya disease in adult patients in particular, like we've been hearing about. So that's a useful advancement as well. And this is an article specifically about headache with patients with Moyamoya disease, which I thought was unique and that came out in 2022. So I'm going to mention some of the information that's in this article and how migraine in particular is important for our patients and providing some insights into how the brain and the vasculature are communicating. So headaches, many of you know this, whether you take care of patients or are a patient, family member, they're a big problem for our Moyamoya patients. And it's been reported that at least 2/3 of people with Moyamoya get headaches. It may be the presenting symptom or it's incidental when the diagnosis is made. It's very often they're migraine-like, so they can be quite disabling. And some patients also have a migraine aura with neurological symptoms like visual or speech, and that might mimic transient ischemic attacks. So that can make it difficult when you have a history of stroke or TIA to sort that out. So this is important for people to know about how there's some overlap here. These headaches, as you guys probably know more than I do, may occur post-operatively and for a while afterwards. But overall, the reports of patients who've had surgery seem to indicate that the headaches overall improve with after surgery. Some specific comments about the headache medications that might be used or may not be used, and Moyamoya was going to mention. Basically, there's no studies on this to really guide us. The older migraine medications, including what we call triptans, usually are avoided as they can cause some constriction of blood vessels. They're very effective, but we tend to avoid them in our patients. Non-steroidal medications like naproxen are very good for headaches, and they can be used occasionally, but not too often. Preventive measures like can be used just like with our non-Moyamoya patients. So these are medications that prevent migraines, and then there's important lifestyle changes with sleep and diet that are important as well. And botulinum toxin injections are not just good for wrinkles, but they can help with chronic migraine as well, and they don't have some of the side effects that you see with medications. Now, what I want to highlight is there's some new advancements in the medications that are used for migraines that came in 2019. And one group is called GPANTs, which sounds kind of funny, but all of them end in that part, that word GPANTs, and they act against pain chemicals, and specifically this one called CGRP. And that seems to be safe in patients with typical vascular problems like heart disease or atherosclerosis, because it doesn't cause vessel constriction. But one caveat is it may not be totally safe for all of our patients, including Moyamoya patients, because it blocks the brain's normal vasodilation that occurs when needed. So this hasn't actually been proven to be dangerous, but you'll see this in this review I mentioned, and that these medications, there may be a concern about it not being ideal, but it's probably safer than the prior medications as well. So it's still unclear whether some of these newer ones are ideal for our patients with Moyamoya disease or other causes of stroke. Now, there are some other options I'm going to mention, and these are called the ditans because they end in that word. And this includes one called Ravo that I'm going to just mention, not because I use it very often, but just as an example of how we're trying to find things that are effective and safe for patients with conditions like Moyamoya. These act in a unique way compared to the other medications, and they don't really affect the vessel tone either, causing constriction or blocking dilation. I think this is the third brain cartoon so far tonight that I've seen. So this is really how the brain and the vascular system sometimes communicate. And migraine, it's interesting. I'm focusing on it because it's teaching us a lot about how the brain and the brain arteries actually communicate during normal activities and during episodes like migraine. And we've learned about the anatomical connections between the two, as well as the chemicals and the receptors that are used in this communication, and actually how medications might be used when the communication is a problem, like in a migraine attack. Now, this more complicated cartoon shows more details on this system of communication and anatomy. So the brain is connected to using the trigeminal nerve, which carries pain sensation from the head and the surface vessels when you're having a migraine, and it releases chemicals that can cause inflammation and other changes where the nerve and the vessels connect. So this is showing you a simplified version of this system, and then this is a sort of magnified system of the trigeminal nerve, which is the main sensory nerve in the head here, releasing chemicals and acting on other nerve endings and blood vessels. Now, these are just a few of the medications you might be familiar with that are the newer migraine medications. And these act on this inflammatory chemical, the CGRP, and it's kind of been designed specifically with this knowledge of how migraine works. And they can either block this chemical from binding to a receptor that then leads to the migraine, or it can be an antibody, a monoclonal antibody listed here, that then kind of grabs a hold of the chemical so it can't bind to the receptor. So what's interesting is we're trying to learn about the importance of the Moyamoya vessel changes and the chronic hyperperfusion, and maybe why this condition makes people prone to migraine and other headaches, and whether there's different treatments that are required because of these in interaction between the disease and the possible medications. Now, one I'm going to mention is lasmiditan, which is also called Ravo, which is interesting, but may not be a good solution for everyone, but it's a unique mechanism of action because it stops the release of this inflammatory chemical, but it doesn't have effects on the vasculature. So this medication, lasmiditan, is shown kind of here binding to the end of a nerve, the trigeminal nerve, which releases these chemicals. So this is just a simplified cartoon of that. But this acts selectively on a type of serotonin receptor, which is different than the other receptors that are acted upon with some of the other migraine medications or some of the antidepressants. So this is one of the other kinds of serotonin receptors, and that is decreases the release of these chemicals, the neuropeptides, and the pain transmission that you see in the system they call the trigeminal vascular system. And this is a quote from that review article I mentioned specifically on Moyamoya. Could be a good alternative for the treatment of migraine in patients who have Moyamoya, as studies show that it does not constrict blood vessels. Now, some of the limitations with this, and I think it points out that we still have work to do to find good treatment options for special populations, are that it's not approved currently for patients under the age of 18. You need to avoid driving for about 8 hours and any activities that require attention because it causes some sedation. And it's quite expensive. It's about $100 per tablet out of pocket, actually. They do have some special coupons and stuff, but that's a limiting factor as well. And it's considered a controlled substance, Schedule 5, like some other medications you might have heard of, one pregabalin or Lyrica. It's not that it's addictive, but it can cause a sense of almost intoxication. So people might get overusing it for that reason. So it got put as a controlled substance. So that's just a little bit of information about the difficulties of headache and headache treatment in this population. Just a little bit to end about seizures, and I won't give it adequate attention right now, but you've heard some. But in children especially, actual ischemic episodes from Moyamoya may cause shaking of the limbs that might be mistaken for seizures, and you've probably heard of this. So it can be a diagnostic challenge. The actual seizures that patients may have are usually secondary to ischemic strokes that have occurred in the past. And there are many good medication options. Some are preferred more than others in this population because they cause less cognitive side effects and risk of birth defects if their patient is of childbearing age. So one of them that's used a lot is lamotrigine or Lamictal. It's still very important to avoid triggers if you have seizures from Moyamoya, strokes, and in particular, sleep deprivation is a very important one. Finally, as mentioned, there's not a lot of specific stroke prevention measures that are medications currently. It's basically unclear if any of the usual measures to prevent stroke are applicable to this non-atherosclerotic disease, Moyamoya. And you saw, I think, the same slide from Dr. Ogilvy of the pathology of a Moyamoya patient, which basically shows thickening of the smooth muscles layer and other changes, but you don't see atherosclerosis. And this is a patient with an atherosclerotic plaque in an artery, and here's the lumen, and here's the necrotic core with a lot of lipids and other dead cells and clots and plasma protein. So it's unclear if the medications we use for this condition apply to Moyamoya. As mentioned, we usually do use antiplatelet medications and usually aspirin if patients have had ischemia or around the time of surgery. General measures to keep all the other arteries healthy are obviously encouraged. If risk factors are present, cholesterol-lowering medications are sometimes used. Blood pressure medications sometimes, but obviously with more caution because of the risk of hypoperfusion. Lifestyle modifications are obviously important, and smoking cessation specifically. You all know about the importance of dehydration and situations that might result in a change in blood pressure. So that's an important sort of prophylactic measure. And as mentioned, there is this risk of hemorrhage later in the disease in adulthood. So blood pressure control is probably even more important. And extra care is required when considering the use of additional antiplatelet medications or anticoagulants. So the future is to really learn more about these other secondary issues in this population. And as we've heard, registries may provide important information on the best strategies to prevent both ischemic and hemorrhagic stroke and how to manage these secondary issues in our patients. Thank you, everyone.
Thank you so much, Dr. Lukovits. We're excited for our next speaker, Dr. Alfred C., a neurosurgeon at Boston Children's Hospital and an assistant professor of neurosurgery at Harvard Medical School. Dr. C. specializes in the endovascular and microsurgical care of patients with diseases of the blood vessels in the brain and the spinal cord. Having developed this expertise, Dr. C. continues to engage in research to better understand normal and abnormal blood vessels. His background in engineering lends to his emphasis on quantitative analysis of blood flow and the application of new technologies, such as computational analysis and robotics. We can't wait to hear his presentation regarding adult manifestations of Moyamoya treated in children.
My name is Alfred, and thank you to the Moyamoya Foundation for inviting me to speak on this topic, which is near and dear to our heart. This is a work that's done in collaboration between the neurology, neurosurgery, and neurointervention groups at Boston Children's Hospital, which is the legacy of Dr. R. Michael Scott, but also in conjunction with Sophia Kocher, who is a representative from the Moyamoya Foundation. This work was supported in part by funding from Brain Aneurysm Foundation, Joe Nuker Foundation, Society for Interventional Surgery, as well as funding established by Dr. Scott and some of Dr. Scott's fellow patients. We're always conducting more research, so we'd definitely love it if you would join us and contribute to the research efforts. So what are we talking about today? This is just a case example to motivate some of our questions and our concerns as we follow up Dr. Scott's patients from several decades. This is an 8-year-old girl who presented with some weakness in the left arm and leg. This will be a familiar story to anybody who's had Moyamoya, and ultimately, she fortunately recovered that strength and was found to have Moyamoya arteriopathy and was treated with a bilateral PL synergiosis. We see here on the left this MRI with the vessel shown in the light gray and bright white. This is an MRA component of the MRI imaging, and we see that the vessels stop here and do not continue onwards towards the side or towards the middle of the brain like they should. This is the carotid artery that's affected, although the vertebral arteries towards the back of the head and the basilar artery, which forms at the junction of the vertebral arteries, that does not have any effect at this time. She didn't have any abnormal blood pressure. She continued on aspirin 81 milligrams, which is pretty standard for our management to improve the blood flow through some of the small vessels that the brain uses to provide alternative supply. But ultimately, many years later, nearly 2 decades, despite having had a good response to the surgery and not having further events with inadequate blood flow to the brain, she actually did suffer a new deficit. And that was because of an intracranial hemorrhage that extended to the ventricles, also called intraventricular hemorrhage. This was almost 20 years after her successful surgery. And during the intervening time, she was living a full and complete life. But we see here on the picture on the top left, this is a non-contrast CT of the head. And here the bright white in the middle of the brain structure and down in this ventricle space as well shows the blood that is distributed throughout the brain. When we get an MRI of the patient, we see this normal brain structure called corpus callosum, and we see this little indentation or injury in the corpus callosum. When this is correlated to the catheter angiogram, looking at the blood vessel structure, we see here not only the Moyamoya vessels are enlarged, but far along in the distal Moyamoya vessels, we see this little abnormality, and that is a little blister at the dead end of the vessel where the bleed occurred. Fortunately, she recovered from this bleed, and with a little bit of help temporarily with a breathing tube and feeding tube, was able to recover and go back to eating normal diet several months later, and even went skiing just under a year after having this second major stroke event. So what happens with Moyamoya that leads to stroke that's ischemic, and how's that different from hemorrhagic stroke? And what's the risk of hemorrhagic stroke, and how does restoring blood flow to the brain address that kind of problem? Ultimately, in Moyamoya, because of narrowing of the vessels that normally supply the blood flow, the brain can suffer ischemic stroke or inadequate blood flow. But on the flip side, in the body's attempt to provide adequate blood, it can sometimes recruit small vessels that aren't equipped to handle it and ask those vessels to do more than they're prepared to do. Those vessels can get enlarged and the vessel wall can get weakened, and that can be a source of bleeding. This is a little bit more commonly described in adults, but in rare cases can happen in children. How does this impact children who grow up after having successful surgery and successful new blood flow to the brain is not really well understood. Historically, many studies have followed children for 5 or 10 years and said that things have looked pretty good and that they haven't had any further episodes of inadequate blood flow. And many children don't really have many bleeding episodes, so everything looks reassuring. However, we're fortunate to have Dr. Scott's experience, and this combined with some relatively recent evidence from the Asian population suggests that follow-up more than 10 years later can start to show long-term impacts of Moyamoya. Even after successful surgery reduces the risk of inadequate blood flow, there can still be a risk of bleeding. Is this risk uniform? What's the nature of the change? Is it early? Is it late? And how does that risk change over time? What are some other factors that could be modifiable to change that risk? And what are some risk factors that are present in patients that can allow us to predict who may be at higher risk? We try to look at these questions in Dr. Scott's patients and continue to follow them up to this day. There's a lot of data just describing some of the features that we're able to collect on these patients. We see here on the left side of the panel, many of these patients were treated relatively young during childhood. So these are all pediatric patients only, and Dr. Scott's overall cohort of 302 patients. And they're treated at about 8 years of age. Just a little over half of them were female. And mostly, these are not Asian populations, unlike the East Asian surgeons in Japan, Korea, and China, whereas majority Asian populations. So this is a different demographic to see if there's any differences in those patterns here compared to the large groups reported in East Asia. There are many patients that are getting bilateral surgeries, more than half of them, and there's a slight predominance on the left-hand side in the ones who are not. Again, we talk about our demographics here. There's a wide range of patients with different ethnic backgrounds and racial backgrounds. What about the middle column? What kind of factors led these patients to have Moyamoya to begin with? And are there certain patients that have a higher risk of bleeding based on the underlying cause of the Moyamoya? So there is a certain population that has radiation, about 5% of those. There's a population that has neurofibromatosis, which is a known risk factor. Some of the patients have trisomy 21 or Down syndrome, as well as sickle cell disease. And then there are other groups that are much more rare in all case series or all case cohorts of Moyamoya, but we have some of that represented here as well. Some of these patients have had tumors before, which led to the radiation treatment, or were associated with neurofibromatosis. So about 1 in 8 of our patients have that. And uncommonly, but still observed, is having high blood pressure. So about 1 in 20 of our patients had high blood pressure. Some things to highlight here, just looking off the bat without doing any statistics. When we see the patients that have late hemorrhage, we've seen 8 of them out of this group of 300. We do notice that many of them have had radiation and a kind of increase in the rate of patients that have had tumors and neurofibromatosis and radiation having these late hemorrhages. Does this bear out when we try to do statistical analysis? 302 patients is a large number, but still small for a lot of medical and healthcare analytics and statistical analysis. So when we look at just the very basic statistics, we do see that if you've had radiation that led to your Moyamoya arteriopathy, the likelihood of having a bleed in the later stages, many decades after having revascularization surgery as a child, you have about a 7-fold likelihood of having a bleed down the road. Neurofibromatosis, when we looked at the early kind of tables, just saying, why is it more frequent? It's suspicious, but we're finding that it's certainly not more than 1.5 times that risk, and statistically, it actually may be the exact same risk as the overall population. Not surprisingly, all these other groups, there's too few patients to know for sure, but we didn't really see significant bleeding in those groups either. Having a tumor is kind of associated with having radiation treatment historically, and therefore we did see that there was some increase in bleeding risk in those patients. Looking at some patterns and just trying to visualize the data more to identify any of these risk factors. When patients were treated, how old were they? Are patients who are treated younger or presenting with symptoms younger more at risk, less at risk, or the same? So this left-hand side table that's kind of more dark right now shows the patients who had no bleeding in the gray and the patients who did have bleeding in the light pink. And so most of the population didn't have bleeding, but the ones who did have bleeding are down at the bottom, and their age range is kind of in the mid-range, and some of the older patients in their teens who subsequently later on did have bleeding. So we did not find any difference in the pattern of these patients. So the age at which they presented and then subsequently had surgery did not seem to differ in the patients who didn't have bleeds and the patients who did have bleeds. What about looking at when they were treated, not what age, but what year? For example, was this something that happens to patients that were treated back in the early 90s versus the late 2000s? Again, the same visualization, the dark gray shows the patients who didn't have bleeds, the pink shows the patients who did have bleeds. And what we see here is that Dr. Scott started treating these patients in the 80s with the Pulcine angiosis technique. And as word spread, more and more patients were being cared for by him. And so there is what's called a skew. So the bell-shaped curve, which you might normally expect, is kind of squished towards the right. When we look at the patients who had hemorrhage later on, there's relatively few of them, so sometimes it can be hard to see the bell-shaped curve. But here we don't see a particular squishing to the left or to the right of the bell-shaped curve. And we did this analysis using kurtosis and skewness to measure how much of that squishing there was. And what we found was there was a right side squishing on the patients who didn't have bleed, but there was not that kind of squishing in the patients who did have a bleed. When we looked at this with a statistical test called the Wilcoxon rank sum, we did find that patients who had a bleed were treated on average about 6 years earlier than patients who didn't have a bleed. So on average around 2002 if you didn't have a bleed, but the patients treated on average around 1996 did have a bleed. It's important to also remember that this is affected by time passing. So it is possible that some of this effect that we see is related to how long we've seen patients afterwards. Obviously, if you had surgery in the 90s, we've gotten to see you for an extra 5 or 10 years even, compared to someone else who had surgery in the mid-2000s. So there's a possibility of that kind of effect, even as we're discussing patients that are being followed up in 2024. But there are other phenomena that change over time. Specifically, the use of radiation in treating tumors has certainly changed. People are a little bit more conservative now than they were in the 70s, 80s, 90s, and early 2000s, because we recognize that radiation can affect cognitive development. And so there's a little bit less radiation treatment now than there used to be. So we also wanted to ask the question, is that difference in patients who were treated in the 90s, on average 1996, who had a bleed, are those different patients who had different patterns? And is that a difference in their radiation? When we look at this similar plot here, we see that the radiation patients have this kind of similar distribution to the patients who didn't have radiation. So the shape of these curves were more similar than when we looked at the prior plots, which showed what year patients were having their surgery. So here we didn't find a statistically significant difference over time of the patients having radiation versus the patients not. However, there is a difference when the patients do have surgery versus, when the patients do have radiation versus not, in terms of how likely they are to bleed. So here we have a survival curve analysis on whether patients have bleeding after their surgery. And we see here at the top of this plot from 0 to up to 30 years in the patients who we've had that much follow-up on. And we see that the gray line here shows patients who had no radiation, and occasionally they could have bleeding later on. But the patients who do have radiation have a dramatically increased rate of bleeding, and those lines spread apart and are not overlapping. So what we are seeing is that patients who have had radiation are probably about 5-fold more likely, even accounting for all the other factors, they're 5-fold more likely to have a bleed down the road, even when they're doing well from the ischemic stroke risk perspective after successful surgery. What kind of problems, or how does this look like in a number of different patients? So this is an example of a teenager who had neurofibromatosis, and they had Pulcine angiosis to treat the inadequate blood flow that was causing strokes and weakness episodes. That worked well, but 7 years later, they started having more episodes, and they actually had a redo surgery on the right-hand side to address that. They also had other complicating factors. They had high blood pressure, they had kidney disease, which also impacts blood pressure, but they were on medications for many of these, whether that's the Ramipril on blood pressure medication, and also they were on aspirin to reduce the risk of ischemic or inadequate blood flow. But they were reduced down to 81 milligrams to reduce the bleeding risk. And down the road, they were switched around on those blood pressure medications to achieve good control, despite all of that. So despite the surgery that provides good blood flow to the brain, and despite not having more episodes of inadequate blood flow, despite having blood pressure now under better control, they did have a bleed several years later. So 23 and 18 is because she had 2 separate surgeries. But whether you're talking about 20 years later or more than 20 years later, this is a long-term late event when the patient is in their 40s, otherwise living a fulfilling life. And here we see a picture on the left. I put a little red circle around a blister that we can see on the CTA technique. And we see the light gray region here, the blood that's inside the ventricles from the bleeding event. And it comes up and tracks towards where that blister was. Another patient who had neurofibromatosis and a glioma that was treated with radiation, as we discussed, probably about a 5-fold increase in risk of bleeding, had an event with ischemic stroke, an event with small bleed, and underwent syngiosis to treat that. They did have some surgical complications, but have been able to recover from that. But nearly 3 decades later, when they're in their 40s, we are seeing this intraventricular hemorrhage on a non-contrast CT head, and a little subtle suggestion on the MRA that highlights the vessels in light gray, that there's a little bit of excess vessel structure here that's enlarged. When we take a look at that in a different direction, I'm going to switch over to the other view just because the video doesn't play well on that presentation mode. Switching to this view, when we scroll through this MRA, keep an eye on that red circle there. Right next to where that bleed event occurred a couple years previously, we see this kind of speckling or problems of the blood vessel structures right in that region. Another patient, this was an 18-year-old boy who had Down syndrome and drop attacks, and ultimately was found to have Moyamoya. They had revascularization surgery on both sides, and they did not have high blood pressure. But nearly 20 years later, when he was in his 30s, he did have sudden onset of loss of consciousness and did have this intraventricular hemorrhage. So again, you recognize the CT that's now the bright white shows the bleeding inside the ventricles. The little blue arrow highlights for you the same region that I will show you on this CTA now, where there's this bright spot. And on catheter angiogram, we see that that bright spot is a little blister on one of these vessels that Moyamoya disease encourages and requires to enlarge to provide an alternate blood flow. 1 year after that, he had recovered significantly, and his right hand was improving, and he was back to speaking, despite having some right-sided face weakness. When looking at his pictures from before, we see the MRA showed that the revascularization surgery had worked on both sides, highlighted by the blue arrows. The blood is going from the scalp into the brain tissue. But over time, we do see that this patient has gradually enlarging aneurysm in this region, which subsequently led to this bleeding events and this blood clot in this region right around where that aneurysm used to be. So what's the driver of the Moyamoya disease bleeds? Is it hemodynamic, meaning is it stress on the vessels, or could it possibly be the same genetic abnormalities that cause the proximal vessels, the upstream vessels, to start shutting down and getting smaller? It's not necessarily possible to prove this completely, but we do have some suggestion even as early as the 1980s when the Japanese teams started looking at where the bleeding events were happening, taking a look at the blood vessel structure, and they were looking at what size vessels were causing the bleeds. And when they looked at those vessels, what was happening in the vessel wall structure. That being said, those were somewhat rudimentary analyses because they only had so much technology back then. The imaging was not as advanced, even if you can look at the tissue afterwards. So how do you correlate that? We have a lot more advances now. And some of the patients, fortunately, continue to participate and contribute to our research. So this is a section of tissue from one of our patients that we recently took a look at. And on the top two panels, we see the Moyamoya disease, typically affecting the carotid artery. So we see this large carotid artery that's gotten narrower and narrower, so the inner channel is very small. We see that naturally the vessel wall structure is much larger than this. And so this lumen, or the channel through here, is shrunken down. When we then look at the deep structure where bleeding occurs, we find a number of different types of blood vessel responses. So it's interesting because not every single blood vessel in a single patient has the same kind of response to the Moyamoya stress. Many of them are enlarged, but some of them can be enlarged with stretched out, thin, and weakened walls, whereas other ones actually are enlarged, but actually with thickening of the line just at the inner surface of the vessel, so endothelial hyperplasia. And on the flip side, there's other vessels in the same patient on the same side where the bleed occurred, where they have subendothelial proliferation, so not the lining of the cells, the way that this other vessel had overgrowth of that lining, but just behind that, there's this overgrowth. And then finally, in another vessel, we see hyalinoization. So this is a response to elevated blood pressure. And in the outer structure, that's the strength structure of these vessels, you see deposition of abnormal collagen. So there's a couple of different responses that we see even in a single patient, which means it can be very challenging to predict which patient will have bleed or won't have bleed, and which vessels will or will not have bleeding. Because even in a single patient, you can have all sorts of different events occurring. If we know that this is a risk factor and it can occur in somewhere around 2 to 3% patients during adulthood after successful treatment of their Moyamoya with a revascularization surgery, can we at least see them coming? Can we see these problems sneaking up on us and start thinking about ways to approach them? This is an area of active ongoing research. This set of pictures is not from our work, although we'll show you some of our studies coming up in the next slides. This is a Japanese group, and they compared 3T MRI, which is a standard protocol at most academic centers and most high volume centers. So this is what you're getting when you're getting routine clinical follow-up scans. And this is on the left-hand side panel. You can start to see some of these abnormal vessels that exist in Moyamoya patients who are requiring extra blood flow because the upstream vessels got narrow. But contrast that in the middle with a 7 Tesla image. Same patient, same scan, but with the 7 Tesla magnet, which is only available in a couple of places around the country. But this shows significantly improved spatial resolution. It's like taking a photo with an older phone versus a newer phone, and you can just see things much more clearly and start to wonder, can you detect aneurysms even under a millimeter in size? And the Japanese group started seeing some of these phenomena, although we still need to think about what to do in response. How do you treat these kinds of small aneurysms? And is the treatment safer than the potential risk of the event itself when you're looking at one patient in a given scenario? These are more examples of small aneurysms that they're finding using 7 Tesla imaging. This is an example of 7 Tesla imaging that we're getting here. We use a clinical 7 Tesla scanner. That's even less common. Many centers will have a research 7 Tesla scanner, but they're not allowed to use that to scan you unless they're enrolling you in a research protocol. And it's a little bit limited what they can tell you about the results of those pictures. Using the 7 Tesla scanner that we have in Boston for clinical use, this is treated just like a 3 Tesla scanner. If you're supposed to be getting an updated picture, a follow-up picture, we can send you to the 7 Tesla scanner if you're older than 15 years of age and get a scan that's got this higher spatial resolution. And ultimately, sorry, this doesn't show the video as well. Ultimately, this allows us to see a lot of these small blood vessels in very high resolution in the deeper regions. So we start to see even very small vessels, and this patient was a different kind of aneurysm question that we're looking for, and we're seeing some of these deeper vessels here. Also, we're doing vessel wall imaging. So with the 7 Tesla scanner, we also give patients contrast to look for any abnormality of the vessel wall. So if there's any bright white of the lining of the vessel wall, that could suggest there's inflammation or susceptibility to a new bleeding event. And you can see this into the spatial resolution in all these little vessel structures. Thank you so much again for inviting me to speak about this issue. ultimately, everything that I know, we learned from the lineage from Dr. Scott to Dr. Smith and Dr. Orbeck, and we continue to train our fellows. This is always a multidisciplinary effort, and that's why we can do the care we do here, only because we have expert anesthesiologists who can get the scans, expert radiologists that are pushing the envelope of what we can look at in scans, as well as our nurse practitioners and our fellows, and people who see you and take care of you day to day and give you critical input and guide you through the recovery process with any procedure, as well as a long-term follow-up as you return to your normal life. We always love to have people reaching out to us and hearing about their stories long-term, and certainly we always welcome people contributing to the research efforts. Please feel free to reach out anytime that you're wondering about your care or your Moyamoya disease, and definitely reach out if you're interested in getting research testing here as well. Thank you so much.
Thank you very much, Dr. C, for sending in that video. Now our final speaker, Dr. Peter Dirks, who is the Chief of the Division of Neurosurgery at the Hospital for Sick Children. Following medical school, he completed his PhD in molecular and cellular pathology and his neurosurgery training at the University of Toronto. He then completed his pediatric neuroscience fellowship training at l'Hôpital Necker-Enfants Malades in Paris. Dr. Dirks also acts as a senior scientist at Sick Kids and a professor in the Department of Surgery and Molecular Genetics at the University of Toronto. Dr. Dirks will now present his talk, How Do We Know If Revascularization for Moyamoya is Sufficient?
Well, thank you very much. It's a real delight to be here and share some of your Friday evening with you. So I thought something really interesting to discuss would be how do we know our surgery is working and who might need additional surgery? And certainly you've heard a lot about surgery today, so some of it we'll go over quite quickly. So I think there's no controversy that surgery is the only treatment that benefits patients with symptoms. It reduces transient ischemic attacks, it can prevent stroke, and for patients with significant bilateral involvement, it can prevent cognitive decline. And many types of operations can be successful, and you've heard a lot about these from Mr. Silva and Dr. Ogilvy. And, I think there are still many questions, and certainly it's a foundation such as this that brings together all these experts. I feel like such a privilege to be with this all-star lineup, but you can really bring people together to try to answer a lot of the unknowns about this disease. And I have this sort of running list that I think about in looking after these patients in my practice in Toronto. But one of the things I wanted to talk about is which patients might need revascularization and how do you go about that? So you've heard again the many types of surgeries, direct, which is the direct sewing of that artery in the scalp into a vessel on the surface of the brain, and that's was popularized in Asia and is done by a small number of people, particularly on the adult side in North America, and it's probably because it's in less use because the indirect is so effective. And here again is the idea here is to get vascularized tissue to contact the hungry brain. Again, as Mr. James was mentioning earlier, it's technically simple. It has a lower risk of stroke than direct, and it has such a high degree of success. And I think, again, having a surgeon dedicated in a high volume center is certainly beneficial, and mainly also from the team approach. It takes a whole group of neurologists, anesthetists, imaging doctors, and surgeons to well look after children. The only disadvantage, of course, is it takes time to mature, and sometimes it's a little unpredictable in some contexts. And something I was curious about early on in my career when I started looking after a lot of these patients is where does the revascularization actually come from? We talk about taking this artery that's in the scalp and attaching that to the surface of the brain in an operation developed in Japan, but then refined by people such as Michael Scott, who you've heard a lot about, and we still follow his leadership, is that this relatively simple operation where one can make an incision directly over the artery, develop that artery, separate it from the layers of the scalp, and then after doing a craniotomy, that artery stays running. So it goes in underneath the bone and comes out and stays running. And over time, all the tissues that are engaged in this operation contribute to the revascularization. But I was wondering, how does this happen? And on the left slide here, you can see work done by a former postdoc or a former fellow at Sick Kids James King, now in Melbourne. We were looking and trying to understand, how do you go from the left picture where there's these squiggly vessels that just supply the scalp to the right picture where after the operation there's rich supply of the brain. What we decided to do is tease out by doing what's called a super selective angiogram, how the blood supply was getting to the brain. And on the top is an injection into that artery that's transposed onto the surface. But on the bottom is injecting the vessels that supply the covering of the brain, this vessel called the middle meningeal artery. And in this instance, the result for this patient is a combination of an excellent revascularization from what you intended, which is to take the artery and oppose it to the brain. And in the lower image is what came from you opening the coverings of the brain and enabling by inverting the surface of the dura, the covering of the brain, onto the surface of the brain, then allowed the vascularized side of that graft to engage and also contribute. And so we looked at the relative contributions of the dural vessels versus the superficial temporal artery vessels in supplying the brain. And we saw that, frequently actually it was the dural vessels, such as this example in the red box here, where the supply is actually greater than the superficial temporal artery. And in other instances, it's about equal. And finally, in other instances, it is the STA which is dominating. So I think this was very useful in thinking about the operation and developing other types of operations that might work for patients in the context of an incomplete revascularization for either a patient who continues to have symptoms or for patients who have areas of concern for parts of brain that aren't receiving all the blood supply that we would hope it would receive after surgery. So who needs more revascularization, and how do we measure operative success? So I think it's measured, first of all, in terms of the clinical outcome. I think it's typical in children and adolescents who are symptomatic, either with bilateral or unilateral Moyamoya disease, that the operation between 6 to 12 weeks is effective in eliminating those types of symptoms and protecting from stroke. And we've angiogrammed a few patients early on for a couple of different reasons, but found that the revascularization starts to engage even as early as 3 weeks. You start to see something happening. And then it generally matures up until 6 months. And I used to think earlier on in my career that the revascularization was done maturing at that point. But actually, in following some patients and needing to reinterrogate with angiography for suspected symptoms, that we can see as the disease might progress internally, the revascularization actually may become more prominent over time. So almost as if what you've done is at the ready to contribute more in time. And we've seen that anecdotally also in other patients we've looked after, for example, of tumors who developed a narrowing of vessels. So not a Moyamoya narrowing, but another type of narrowing where they naturally develop collaterals from the operation you did at the time of their tumor surgery. And so that there is this phenomenon of having the vascularized tissue available to the brain that's asking for new blood vessels. We have found, at least at sick kids, that angiography is extremely helpful to helping us understand where the revascularization is going. And still there's an aspect of the dynamics of the seeing all the branches and the kinetics and how the blood gets into the brain that's still useful. So I still think despite this being an invasive test, the information it gives is extremely useful. However, as you've heard from Dr. Lehman earlier, I think it's very exciting to consider other non-invasive techniques such as diffusion tensor imaging and analysis of white matter volume, but also looking at some measurements of dynamic cerebral blood flow, or the ability of the brain to augment flow under conditions of a physiological stress. And here's a technique that was developed by David Michaelis together with Gabrielle de Weber years ago, and then pushed on by Bill Logan, and now really led in such a fantastic way from a research perspective by Noma Delamini, who's a neurology colleague at Sick Kids. And we get these maps of the brain that are shown in these colors. So this is an example of a patient I looked after who had involvement of the left-sided vessels at first, and they got and on the left side of the brain, you can see more blue, and blue for this patient represented steel. So this MRI was done with a patient either holding their breath, patients who are old enough to be awake in the MRI, who can cooperate to a breath hold. During a breath hold, the brain naturally, blood vessels should dilate and augment flow. But in the setting of Moyamoya disease or syndrome, because the vasculature is abnormal, you can actually have areas of the brain that which should normally augment that actually decrease in flow. And so here's an example of a patient who has more blue on this left hemisphere, shown in this little thumbnail at the top here. After surgery, the patient showed somewhat increase in red and orange on this side, still limited in the frontal area, but now developed disease on the other side where previously had been red and orange is now gone blue. So then I moved to operate on that side, did another operation, and you can see in follow-up again, there's an improvement, but still there are some areas of concern here, particularly in this left frontal area and in the occipital area. So what do we do about those, particularly in the asymptomatic patient? And so how much of the brain actually needs to be revascularized? And I think we focus on symptoms, but then how to decide what kind of operation to do in those different regions. Obviously, if it's the frontal area, that's the non-hair-bearing forehead. It's an important cosmetic area. We can't just make incisions there. And so we try to think about operations we can do to improve the supply and still have all the surgical scars hidden. And still, I think we need to do more research on how to better revascularize those areas that are silent. And certainly, of course, our good colleagues in Boston have been looking at this, and they found that areas that show hypovascular territories 1 year after operation are areas that may predict additional symptoms in the future. So it really behooves us to better identify what those areas are and to consider whether our operations have been sufficient. And so what kind of operations can be done in the setting of need for reoperation? Well, again, one could go to direct if there's still superficial temporal artery available, but there's a whole suite of additional operations that can be provided. And here's an example of another one that Ed Smith and colleagues from Boston showed a nice operation to take the immediate layer of sitting on the external surface of the skull called the periosteum, and taking this large pink flap shown in B and peeling that off the skull. And then after the skull is open, and then that pink flap is laid down onto the brain. And that's a very effective additional way to provide revascularization, even if you don't have a significant branch of artery. I'm going to show you an example of a patient I looked after recently who had a multiple burr hole approach to the operation to deal with bilateral Moya disease with bilateral strokes. And just on the top here, you can see how severe the disease is, particularly even in the middle is the posterior circulation, which usually is less involved. And so the results of both the left and right postoperative follow-up angiogram shows that the burr hole operation did work. So you can see here, particularly on the right, there's a splash of significant revascularization here related to those burr holes. But there's a lot of areas in the brain that aren't getting much supply from that operation. And so in order to understand, and this patient was still having symptoms and there's still concern for additional stroke. So as you saw Dr. Ogilvy show, a CT angiogram with 3D reconstruction can be very useful for us to look at all the vessels present outside of the skull that could potentially be used in an operation. So in this context, you can see all the little holes that were made previously, and you can still see, for example, that some of these vessels were actually not utilized for the operation. And even at the back, there's these arteries called the occipital arteries that were still available for surgery, even though we could see some of the branches got engaged through the holes that were made from the previous surgery. And so with this, I drew out a map, and in red it was where the patient's incisions were, and I drew out a map of all of where the revascularization was, where it was effective, and where the arteries were present. And so ultimately, I was able to, for this patient, through SCAR, to develop both superficial temporal arteries and also both occipital arteries and provide additional revascularization for this patient. And you can see here, just in the red box here on the right, is the additional revascularization that was provided by the additional surgery, where there was something getting in before that we didn't disrupt, but now it's much richer supply to that hemisphere. And as well in areas in the blue box here, where the occipital lobes weren't getting any supply, that in taking that occipital artery and laying that down onto the surface of the brain, like we do with the standard operation in the temporal area, was very effective in getting new blood supply to help nourish this patient's brain. And afterwards, this patient was stable. So certainly, I think this requires some creativity, some careful thinking about what was done, because you never want to disrupt what already is existing, because those pre-existing areas of revascularization may be critical, but what we need is augment and not disrupt what was existing. Something that I look at very carefully is what's called the leptomeningeal collateral supply. And typically, most Moyamoya patients don't have involvement of the posterior circulation at first. Those are the vessels that are at the back. And this shows an injection of the vertebral artery, which supplies the posterior cerebral arteries at the back. And here there's no involvement of Moyamoya disease, but you can see in this patient who had very significant disease, typical disease in the front with the internal carotid arteries, you can see that the posterior cerebral arteries are providing a tremendous amount of supply, almost taking over for the temporal lobe supply and coming around the corner and coming forward to help supply the brain. So it really requires a careful look at all these different facets of the angiogram and the previous operations to know what one might do. And certainly as the disease progresses to involve the posterior circulation, if this was critical in supplying all the area at the back of the brain, now that would be vulnerable and possibly could require additional surgery. Fortunately as well, when all the vessels and tissues are used that are available in the scalp, one can go to do an operation where you take what's called the omentum, which is the well-vascularized fatty tissue that drapes over the organs of the abdomen, and you can actually, usually together with a general surgery colleague, develop that tissue and even thread it underneath the surface of the chest and right up the neck to applying that onto the brain if necessary. So I've not had to do that operation in my own practice over 25 years, but I know it's an operation I've seen, and again, as well, one needs to apply that vascularized tissue closely to the brain. So again, the cardinal feature of this disease is a brain that's hungry for blood supply. And if you give it vascularized tissue, almost any operation can be beneficial. And this is the result where an injection of the vessel that goes to the stomach actually now has been rerouted to go all the way up the neck. And this shows the splash of supply that is occurring in the head. And this is an example from a published paper. So I'm going to stop there and let you get on to your weekend. But I think there's a lot of work that we need to do in this area. So, certainly all the areas of the brain are important for different aspects of function. And fortunately for children and adolescents, there is an operation that works very well, the indirect Pulcine angiosis operation. But that operation mostly supplies the middle area of the outside of the head, the middle part of the cortex, which supplies the motor and sensory areas. So that's why it's very effective in reducing those types of motor sensory transient ischemic events. But that operation doesn't well revascularize the middle part of the brain. And so there's operations that can be very beneficial as well, using either the galea, which is a layer of the scalp, or the periosteum, another deeper layer of the scalp, to lay in and opposed to this brain that's asking for new blood supply. I think the frontal areas are also more challenging. I've done some surgery there using a fan of periosteum together with its basal vascular supply. But that's using sort of more incisions that go ear to ear, or extending prior incisions. And I think the temporal regions are vulnerable if the disease progresses to the posterior circulation. Those are areas involved in speech and language and memory function. So, but you can do additional things posteriorly with muscle or with the occipital artery. And I think we really need to continue to develop non-invasive assessment of cerebral blood flow. And at our place, functional MRI is certainly becoming very helpful into planning for children who may have areas that, as I showed, that maybe not getting all the blood supply that we hope for. And so I think we will continue to study, and Laura Lehman mentioned that in her own research work, and certainly collaboration here is critical. So some of the research questions I would like to see focused on is, again, focusing on how to measure which patients still need something more, and particularly in the frontal areas which are involved in the cognitive function. I think we need more study of what the role of the collaterals, the natural collaterals, exist in the brain and how those contribute and predict the quality of revascularization. I think a brain that's ischemic that is capable of getting new blood vessels to grow into it must be releasing biomarkers that would tell us when revascularization is sufficient and when there's a brain that's still asking for more. And again, better evaluation of the quality of revascularization non-invasively is truly needed. So on behalf of my colleagues, my medical colleagues who help us look after the vascular patients, Noma, Mahendra, and Liza, and also my new neurosurgery colleague at Sick Kids, Jennifer Kwan. It's a privilege to be able to look after patients with Moyamoya disease. And I'm inspired by this group and really appreciative of the opportunity to speak to you today. And hopefully, as we work more and more together, we'll make significant advances in all the different facets of this challenging disease. Thank you so much.
Well, thank you so much, Dr. Dirks, for the final talk this evening. So as we bring this event to a close, I just wanted to thank, of course, the speakers for their incredible presentations and for taking the time out of their very busy schedules to share their valuable knowledge and insights with us. So again, just to acknowledge Mr. Silva, Dr. Pulcine, Mr. James, Dr. Lehman, Dr. Ogilvy, Dr. Lukovits, Dr. C, and Dr. Dirks. Thank you so much for making this event a success. So I also just want to take a brief moment to acknowledge some other groups that are doing some really amazing and important work. So the first is the Credit Union's Kids at Heart, which is a Massachusetts-based nonprofit organization, and they've worked very closely with our friends at Boston Children's Hospital. The other, which you've heard a little bit throughout the various presentations, is the International Pediatric Stroke Organization, or IPSO. It's an academic organization of scientists and clinicians who are committed to advancing research and clinical practice in the areas of pediatric stroke and cerebral vascular disease. So the Moyamoya Foundation was actually very pleased to recently attend the IPSO conference that took place at Sick Kids this year. And we connected with many brilliant clinicians and researchers who are also very invested in moving Moyamoya research forward. So definitely feel free to check out their websites. So lastly, of course, I would like to thank you, the audience, for attending this seminar. We hope that it was valuable and interesting to you all. While we don't have time for a full Q&A session today, we will be reviewing the chat feature for any questions that were submitted during the presentations, and we'll get back to you about those. If you would like to learn a bit more about our work at the Moyamoya Foundation, definitely please visit our website. And you can also follow the Moyamoya Foundation on various social media accounts that are detailed on the screen. If you have any ideas for any future events, or you would just like to become involved, please reach out to me or Dean Houle, who is the Moyamoya Foundation president. And we just want to remind everyone that the event has been recorded and it will be available for viewing on YouTube in not too long from now. Thank you again very much for this wonderful event, and we hope you have a great weekend. Thank you so much.